Well, we're so grateful that you could be here with us for our first CME conference for pediatric rural healthcare. We're proud of our alliance with Children's Healthcare of Atlanta and so proud of the opportunities that they have opened up for us to be able to offer this for rural Georgia. You here today are the heart of it. You're at the heart of everything that we do because you are out there serving, taking care of, raising the future of rural healthcare. And so because of you and because of what you're doing today and in the future, rural Georgia will be healthier. And when you listen to people on the television shows and even sometimes under the dome, they'll lead you to believe that rural Georgia, nobody wants to be there and it's dying and it's not a good place. And we're here to say, hey, wait a minute. We are those people. We were born and raised in rural Georgia. We choose to stay there. But we also believe that because of your zip code, you shouldn't have to compromise in care. And so we're out there every day doing that work to make rural healthcare better. And that's, we're so grateful to you because we know you fight that fight every day. And we're so grateful to our partners at Children's for allowing us to be able to come in and do that work and supporting us and coming along behind us to say, you guys are really important and the work that you do is very important. So we're grateful for Children's. We're grateful that you're here today. I think we're going to have a great day. And so with that, I'll turn it over to Pam Mason.
Oh, they took my picture from LinkedIn. That was a few years back. So I'm Pam Mason. I am the Director of Affiliations from Children's Healthcare of Atlanta, and have been working, the work that I do is outside of Children's. So I've past 10 years, I've worked outside of the Metro Atlanta. And so now we are expanding to all of Georgia, which is wonderful. But as you know, Children's Healthcare of Atlanta has been dedicated to providing the best care possible to sick and injured children, and to helping kids stay healthy through our advocacy and our prevention programs. Those programs have been statewide for the past few years, and Children's recognized there was a need to expand even further. And so we were thrilled to go into a partnership with Mercer University School of Medicine and the Rural Health Innovation Center because we knew that they have the relationships with the community that we know is valuable, and that they hold the key to understanding how can we best help the communities outside of Metro Atlanta. And so we believe that together we can make a huge impact in the lives of children here in rural Georgia, and for now and for in their future. So, thank you.
Good morning, everyone. I am Kedrick Williams, and I serve at the Georgia Rural Health Innovation Center. Certainly happy to see each and every one of you all here. I have been asked to provide information regarding continuing medical education and continuing nursing education credit. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the Medical Educational Council of Pensacola, MECOP, and the Mercer University School of Medicine. MECOP is accredited by the ACCME to provide continuing medical education for physicians. The Medical Educational Council of Pensacola designates this live activity for a maximum of 4 AMA credits. In accordance with the policies of the ACCME, MECOP has collected disclosures from the speakers and planners involved in this activity. None of the planners or reviewers associated with this activity have relevant relationships with ineligible companies to disclose. The speakers, as you see listed below, do not have any relevant relationships with ineligible companies. Continuing nursing education credit. Three Rivers AHEC is an approved provider of continuing nursing education by the Alabama Board of Nursing for a maximum of 4 contact hours. Nursing participants should only claim the credit commensurate with the extent of their participation in the activity. Three Rivers AHEC has collected disclosures from the speakers and planners involved in this activity, and none of the planners or speakers for this activity have relevant relationships with ineligible companies to disclose. Our first speaker for this morning is none other than Dr. Keith J. Mann, who comes to us from Chapel Hill, North Carolina, with the American Board of Pediatrics. He currently serves as Vice President of Continuing Certification for the American Board of Pediatrics. His academic appointments include being an adjunct professor of pediatrics at the Duke University School of Medicine. He was educated at Harvard School of Public Health, obtaining in leadership development, the University of Cincinnati, his degree, a master's degree in education, Harvard University School of Public Health, as well as the New Jersey Medical School, where he obtained his medical degree. Postgraduate training included pediatrics as chief resident of the Thomas Jefferson University and Al DuPont Hospital for Children in Wilmington, Delaware, and Philadelphia, Pennsylvania. His additional training is varied among various leadership development programs, leadership development at Children's Mercy, Kansas City, and the Human Interaction Laboratory of NTL Institute for Applied Behavioral Sciences. Ladies and gentlemen, I welcome to the podium at this time Dr. Keith J. Mann.
Thank you so much. I want to thank you, Kendrick, for the kind introduction, and thank you all for welcoming me here. This is my first time to Macon, and I got a chance to spend some time here yesterday. It's a gorgeous campus. Got a chance to drive downtown, have dinner. I always like to explore where I am locally, and really everybody from the people at the hotel through the people who I had dinner with last night greeted me warmly. So thank you so much. You might be wondering why is the opening talk about continuing certification? How does that fit into what we're thinking about today? And I want to say, previous speaker, Pamela mentioned the partnership between Children's Healthcare of Atlanta and you all here. Well, now the Mercer University and the Rural Health Innovation Center have a formal partnership with the American Board of Pediatrics. And I'll mention that a little bit towards the end of my talk today. So I'll start by giving an overview of who the American Board of Pediatrics is, kind of get some nuts and bolts of maintenance and certification. So for those of you in the audience that are pediatricians, try to help you see the program in ways that it actually can help benefit your practice instead of looking at the American Board of Pediatrics well, how some of you might look at the American Board of Pediatrics over time, your certifying body. And then spend the last 10 minutes or so talking about the fact that this group now is a pediatric portfolio sponsor and a partner of the American Board of Pediatrics and what that means for you all moving forward. So I have no disclosures. Here are some of the learning objectives that I hope we achieve today. And then so the agenda will be a brief overview of the American Board of Pediatrics, some nuts and bolts of maintenance and certification, and then what does it mean to become a pediatric portfolio sponsor and how does that benefit all of you? So the American Board of Pediatrics is made up of about 105, 107 staff and about 20 contractors. We have an office that's in Chapel Hill, North Carolina. It's smack in the middle of Duke and UNC. So this has been a great football season, and Final Four season is crazy. You do not want to declare your allegiances while you're on our site. Even 105 people can get pretty rowdy that time of year. But the reality is the American Board of Pediatrics is made up of pediatricians. We have over 400 physician volunteers. Those physicians make up a board of directors, general pediatrics committee. And so again, for those of you that don't know the board, it's pediatricians who write the questions for the initial certifying exam, pediatricians who write questions for MOCA Peds and continuing certification. We also have the 15 subboards for the people who write the questions for all the subspecialty exams. We have a family leadership committee, and then we have a bunch of other levels of involvement. So I run a continuing certification committee, and it's the people who give me advice on how to run a continuing certification program for the American Board of Pediatrics. About 3 years ago, recognized that in the 15 years of this committee, there had never been a rural pediatrician on the committee. So 3 years ago, we appointed our first rural pediatrician who comes from Eastern Tennessee. She's part of a 4-person practice in Eastern Tennessee, and she helps guide the continuing certification department where we work about what it's like to be a rural pediatrician and how we might be able to meld a program that would work more for people in communities that we had not been receiving feedback yet. So that's been tremendously helpful. I'll also say that just a handful of little things, if you're ever interested in volunteering with the American Board of Pediatrics, feel free to come and chat with me after this. It can be a big committee volunteerism, or the pediatricians also actually help set the standard for what comes to the exam. Every 5 to 7 years, we do something called standard setting, where we talk to pediatricians who take care of patients day in and day out and ask them what they do. And what they do and their estimates of the percentage that they do it is what ends up making it to our exams, especially the continuing certification exam. And so when you think about, some of you hopefully are in MOCA Peds right now, which is kind of an online longitudinal assessment. We are seeing a lot of positive feedback about the relevance of those questions. So I think what we're getting is that the pediatricians that we were asking about what you do in practice is hopefully translating into the questions that you're seeing on MOCA Peds. And then lastly, the pediatricians actually set the passing standard. And so the passing standard for each of our exams are set by pediatricians who look at the content and are working with us to figure out about what percentage should a pediatrician practicing get right. So the reality is American Board of Pediatrics is an office. It is 105 staff, but the reality is the American Board of Pediatrics are the pediatricians who volunteer with us, and we can't thank you all enough. We started doing more engagement outside of just our volunteers about 5 to 7 years ago, getting out more, giving more talks, engaging with local communities, especially AAP state chapters, bringing in people to do focus groups. And one of the first focus groups, we asked people what they thought of us, what they thought of the American Board of Pediatrics, and that's the word cloud you see on the screen. Some positive words, interactive, evolving. Evolving's mostly positive. Flexible. But then other words up there, intimidating, expensive, confusing, rigid. Most of you in the room don't know me. You might think of me in some of these terms if you knew me well, but I think most people who get to know the people at the American Board of Pediatrics, that's the last way we would ever want to be perceived. We want to be engaged with pediatricians. We want to be partners with all of you. And the reality is we are a certifying body, which comes with some expectations from the public, but we want to partner with pediatricians to develop a program that's meaningful and valuable to all of you. So our goal is to change this word cloud. I'm not ashamed of the word cloud because it's how we're perceived, but it's certainly not the way we want to be perceived long term. So then jumping into maintenance certification, what does the program look like and how do we want to evolve the program to make it more valuable for all of you, and what have we done so far? So there's several components to continuing certification. We're going to spend a lot of time talking about the second, third, and the fourth component. The idea of self-assessment, so learning and self-assessment. How do we work to make sure pediatricians are staying up to date with practice? How do we administer the ongoing assessment of knowledge, and what are the quality improvement opportunities look like? So this is a quick snapshot. Feel free to use the QR code. It jumps right to our website of what the requirements are for continuing certification. And so if you keep up one certificate, everything in the left side of the screen, the wheel, applies for no matter how many certificates you uphold. If the stuff to the right side of the screen, you take multiple exams if you happen to hold multiple certificates with us. But the idea is there's a certain amount of Part 2, which is lifelong learning and self-assessment, and a certain amount of Part 4, quality improvement, that's required. And then there's an exam component. And we've shifted that exam from a point-in-time proctored exam to an online exam, which is delivered quarterly and we believe is much more beneficial to pediatricians. And we'll go through all of that in a bit of detail. So starting with self-assessment. So there's components like 50 Part 2 points, and I don't like to think of things in points, but it's like CME hours in some way that we require over the course of 5 years. And we've tried to expand the opportunities to get credit So they're available to people all over the country. And so these are different ways that we offer ways to get Part 2 credit. So I'll fly through the first two and then spend a little bit of time on the third. So one is we partnered with the Accreditation Council for Continuing Medical Education. So most CME can also count for MOC Part 2. What it requires is that the local CME office or the local CME provider register the activity for Part 2 and have your ABP ID numbers. If that happens, you actually can get, so say you go to Grand Rounds and you're not currently getting MOC Part 2 for it, you can actually register, the local CME provider can register that activity and you get credit in the background. It actually passes through the CME offices just like any CME credit that you might have. That applies to things like UpToDate. So if any of you use UpToDate to search information and try to learn about the patients you're caring for, you can link your UpToDate account for CME, and you can also link that account for MOC Part 2 just with your ABP ID number. So there's relatively easy ways to get credit for your continuing certification world with some of the work that you're doing. If you keep up any of your resuscitation certificates, you can easily upload those for credit. And then if you're learning about diversity, equity, and inclusion in your work environment, you can simply attest to the work that you're doing and claim the amount of hours that you've learned. But what I want to focus on really is some of the activities we produce that we hope help you keep up to date with the medical literature. And the first is called Question of the Week. And so 50 weeks of the year, we pull an article, provide an abstract, write a single question with a 1,250 word summary, the same exact question a second time, and then key takeaway points. What we're asked over the years by pediatricians is don't just test me. Like, we know you're a certifying body, but we want you have a role to not just test me, but also help me keep up to date. And so this is one of the efforts that's out there. So here's a quick snapshot of some of the questions of the week in May of 2023. The one I will share on the screen is related to overuse injuries. There's a case study, which starts with a brief description of a patient. There's then a single pretest question, an abstract that's provided from the literature, a 1,250 word commentary, and then takeaway points. And then for those of you interested in looking at medicine outside the world of a typical case scenario, there are medical pearls, which are really well written. I often skip them because I'm doing something else. But for people who love medical history and literature, the medical pearls are absolutely fascinating. So this is a kind of a typical case study. And then key takeaways. So you can find question of the week within your ABP portfolio. The first time you answer a question correctly, it will then email you the question of the week every week into your inbox. You can ignore it. There's no requirement to do any certain amount of questions. Some people do 1 a year. Some people do 50 a year. So there's 84,000 certified pediatricians, and about 30,000 now are signed up for question of the week, and about 10,000 do it on a regular basis. And we typically get almost universally positive feedback on this. So easy way to keep up to date with the literature, learn about 50 new articles each year, and then it's really geared towards general pediatrics. So we hope it helps you in your practice. The second thing we've worked hard on is an activity called Decision Skills, and it's supposed to, the goal is to help with clinical reasoning. They're case-based studies in a multiple choice format, similar to an exam, except that we can do a lot more when you're not in an exam format. So the cases are a lot longer. There are often multiple laboratory studies and/or diagnostic studies built within the case. And it's really, again, meant to think through clinical reasoning. We used to have just the forms, like a 50-item form or a 25-item form like you'd produce for an exam. And we recognize that nobody wants to, I shouldn't say no, most people don't want to spend time going through a 50-item form anymore. And so we've broken them up into things that you might want to learn. And so during COVID, we produced 10 questions around COVID, which we hoped would help stimulate learning in that environment. We have one for behavioral mental health, endocrinology, hematology, oncology. We're working on one right now for cardiology, and I think we just released one last week for infectious diseases. So these are 5 to 10 questions on a topic you might be interested in, and you can just delve into clinical scenarios, answer some questions, and then try to learn. And again, all of this kind of applies towards your continuing certification credit. And then lastly, we produce article-based self-assessments. And again, with the idea of trying to help keep up to date with the literature, we try to produce article-based self-assessments in areas that are relevant to general pediatricians. Knowing that you also have a DEA requirement that just came up last summer, this is one that's about adolescent substance abuse and mental health. So it's a self-assessment. I think this one has about 7 to 8 articles pulled from the current literature with about 20 to 25 questions on a topic. And so again, the goal is to help keep you up to date. And then with this one specifically, you can get CME, partial credit for your DEA, and then also credit for MOC. So we're trying to link things so you can do multiple things with more impact. So now jumping into MOCA Peds, which is our online proctored exam. And so again, for those of you that aren't physicians in the audience, for once you pass your initial certifying exam, the expectation is ongoing certification. And one of those expectations was an exam at a proctor testing center every 7 to 10 years. And the feedback regularly was, I don't want to go to a proctor testing center for the rest of my life. It's not valuable. I cram, I don't learn. And it's that's not an environment that's conducive to ongoing certification. And so back in 2018, we piloted an online longitudinal assessment, and that is now standard practice. And so what is MOCA Peds? So the goal is to focus on assessment and learning. Again, don't just assess me, help me keep up to date and help me learn. And so it's up to 17 questions get delivered each quarter for each certification area. It can be either via your laptop, desktop, or a mobile device. You take the 17 questions, one question at a time. Once you take the question, you actually then get the answer right away. Actually, you rate the question to your relevance, how relevant it is to your practice, and how confident are you that you got it right or wrong. You get the answer, and then you get a 1 to 3 paragraph summary of why the answer was correct or incorrect with references. You take those 17 questions each quarter over 4 years, but we allow you to drop your 4 lowest performing quarters. So whether you skip a quarter, don't do well in a quarter, or decide just to crank right through, we'll always drop your 4 lowest performing quarters. So you can imagine if it's a 4-year exam, 16 quarters, and you just crank right through, you do the first 3 years and you do well, we'll give you your score at the end of 3 years and let you know you've passed, and then you have years 4 and years 5 off of your cycle. So the idea is it's meant to work into practice in a way that's much more compatible than a proctored exam, and then hopefully much more valuable. So we also introduce 1 to 4 new articles per year. They're chosen by experts in the field. We ask that you don't work with a colleague. It is an assessment of individual knowledge. That's our responsibility as a certifying board, but you can use resources. So I pull up to date on one screen, and then I have my questions on the other screen. We give you repeat questions. And so of the 17 questions per quarter, so you get about 70 per year. There are about 10 to 15 repeat questions. And so if you've gotten them wrong, or if you've gotten them right and rated them highly relevant to your practice, we'll feed them back to you. Again, the goal is not to trick you. We're not trying to fail people on an exam. 98, 99% of people who do all the questions pass MOCA Peds. The goal is to help you learn. So it's the concept of spaced repetition learning, where if you see something that's relevant to you, you will then subsequently learn it and incorporate it more if you've seen it a second time. And there is the option to still take the traditional exam if this isn't for you. So this is a quick snapshot of what it looks like. There is a question, the rationale right afterwards. You can bookmark a question. So again, you can go back and look at your question history. So if you've gotten a question wrong, bookmark it. Go take a look at it again, because you'll see it again. Question 2, 3, or 4. Sorry, quarters 2, 3, or 4. You're likely to see the same exact question again. There is information in the screen about your question history, as I mentioned. And then also exam content and your performance. You can continue to look about how you're doing, and you can look at the learning objectives in advance and the articles in advance. On our website, we have a dashboard that shows the data for MOCA Peds. It shows all the passing rates. It shows all the relevance ratings. And so there's nothing, we don't keep anything about this secret. Like, it's all out there for you if you wish. I'll just show you a little bit of the data that we have. So we ask pediatricians, did you learn enhance your medical knowledge based upon taking MOCA Peds? And you can see the graph to the left-hand side of your screen. And so between 87 and 92% of pediatricians enhance their knowledge via MoCaPeds. And then about 65 to 70% apply what they've learned to their practice already. The remainder of that gap, about 10% say, I haven't applied it yet, but I can think of ways I will. And then about 15% are subspecialists taking general pediatrics who actually say, I'm either not practicing in the field or not practicing at all. And so the majority of people who are taking MoCaPeds both learn and then apply it to their practice if they're clinically active. And they apply it to their practice in multiple ways. The first graph says, I learned something specific. So the first graph is what we expected. I learned something specific. And I learned it in a way that changed the way I practice. I prescribe a different medication now for pneumonia. I used to prescribe a more broad spectrum, and I've narrowed it down to amoxicillin. Or I diagnosed Kawasaki disease. I hadn't seen it in private practice for 10 years, and I just had a question on it, and it was great. The timing was perfect. I diagnosed it the week after. The next couple columns are the ones that even intrigue me more. They've changed the way people practice. I look up articles more. I search the literature more. I'm practicing more evidence-based medicine. I'm engaging with my patients differently. And that's what I really want to see. The reality is the goal of any certification program is to stimulate pediatricians who are thirsty for knowledge and interested in caring for patients and interested in improving that care to do so within the context of a productive partnership with their certification board. And that's what, so I'm really intrigued by the other bars that suggest people are making these metacognitive changes to the way they practice. So I'll jump into the last one, quality improvement, and then wrap up with discussing you all being a portfolio sponsor program. So first, people ask me all the time, is there any evidence to support quality improvement as a component of continuing certification? And I'll be honest, the evidence isn't great, but I'll share the evidence that exists. So the first is, if you're ever interested, a paper published by David Nichols, our old CEO, does a really nice job of summarizing all of continuing certification. It was published in Pediatrics in 2017. It's a nice article to breeze through, but it summarizes the idea of professionalism in the context of self-regulation, which is what we are. We're a self-regulating body as a field of pediatricians. So in that study, in that paper, though, he summarized the impact of which QI studies and MOC is awarded, and he cited over 30 studies in pediatrics which support the association of MOC Part 4 with improved care and the importance of MOC credit as an incentive. And please know it's not cause and effect, right? It is truly just an association. So it's a weak body of evidence, but that's the evidence that exists. I think the thing that's most powerful, though, is the second part of it, which is the importance of MOC credit as an incentive. And since that article has been published, I just pulled 4 more that we've seen recently that talk about the value of MOC as an incentive to engage pediatricians in quality improvement. And then the goal is, from being engaged in quality improvement, people find a passion to improve the care of the patients that they are engaged with. And that's a lot about being a portfolio sponsor organization, which I'll get to briefly at the end. So our goal is to make this QI component more meaningful, less time consuming, less burdensome, and more relevant to all of you. So how have we thought through that? The first, and so this is just a slide that shows the different ways to get your credit for continuing certification for quality improvement. All the way to the right of the screen are our online performance improvement modules. This was the old hand washing module that we got a lot of flack for. 22,000 people used to do our online performance improvement modules back 7 years ago. That's now down to about 5,000. So about a 63% decrease. That's a purposeful approach. The old modules used to get a lot of flack. I think they were relatively well built, but there wasn't any possible way to have enough modules that pediatricians could do. So people were just going through an exercise in futility, going through an exercise to check a box for continuing certification, which is, again, the last thing I would ever want to have happen. So as the numbers went down from about 23,000 to about 5,000, the relevance ratings have skyrocketed. And so the relevance ratings are now up in the 92 to 95% range for all of our modules, because I think people are doing them because they find them relevant to their practice, not that they have to. We still get feedback that there's not a lot of other options, and I'll share with you some of those that exist. So to the left of your screen are large-scale QI projects. That's mostly for subspecialists. Like Improved Care Now is a big network for GI docs who care for inflammatory bowel disease. But there are some for general pediatricians. There are several AAP state chapters who run large-scale collaboratives, South Carolina and Tennessee being 2. But again, most commonly, pediatricians are getting credit from the second or the third box. The second box are workplace-based QI. I'm doing something in my workplace, and I'm able to get credit for it. One is you can apply directly to the American Board of Pediatrics, but there's an extra step in there. You have to take your work, fill out an application, apply through us. I'll show you the criteria for that, but it's an extra step. 103 organizations now, congratulations, you're the 103rd, are actually giving credit on behalf of the American Board of Pediatrics. So we partner with organizations, so the QI work happening locally, you can all get credit for. And that's what it means to become a portfolio sponsor. And again, I'll wrap up with that. If you're part of an NCQA patient-centered medical home or any other patient-centered medical home now, you can actually get credit for that partnership. So here's just a brief snapshot of our requirements. If you happen to know quality improvement well, you'll look at these requirements, and quality improvement experts want us to always strengthen them. The reality is we know half of general pediatricians have never been trained in quality improvement. And so the requirements are pretty straightforward. There's got to be a known gap in care that you've identified, some intervention, a single measure, and a couple points of data to say that there's been some effort to improve over time. Nice thing is you can get credit. One person can do an application and 10 others can get credit. And we do have some coaching. If you've never done quality improvement before, reach out to us. I spend probably a day or two a month chatting with practices about how to do quality improvement in their practice. And I'm happy to help in any way. We also have a staff of people who are happy to help in any way. This is just an example. We're talking a lot about mental health today, so I wanted to pull a mental health example for all of you. This is from a rural practice of, I think, 4 or 5 pediatricians. They had identified depression screening as a gap. They implemented improvements in depression screening and got their screening rates up, I think, to about 90%. That was their first application. But in improving their screening, they recognized that only 4.5% of their screens were positive. And they said, there's no way. We know just from being in our community that the rates of depression are higher. And so they regrouped and said, well, if we're going to screen, we might as well do it effectively. And then you can see their measures, a series of interventions, all designed to improve the quality of their screening measured by the percent positivity. They were estimating that they had about a 10% prevalence in their community of pediatricians, of patients, and we're trying to up their rates to come closer to that. And you can see they did this over the course of several months, and they almost doubled the percent positive rate. And again, the goal is not to double the rate. The goal is to get a more accurate reflection of what's actually in your community, and they were really proud of this work. The last thing I'll mention again, to try to link this to some of the behavioral mental health topics today, we also have modules or templates that are available for you if you don't know what you want to do in QI, but you recognize a gap in the behavioral mental health care that you're providing. And so this is a roadmap project, and it was designed to help support the emotional health of children and their families specifically with chronic diseases, but it can apply outside of that as well. It's a really fascinating project developed with pediatricians who care for children with chronic diseases and the families of those kids, partnered together to develop this template. It's about the simple ask to, when you're engaging with patients with chronic disease, to not forget about their mental health. Simply asking, the parents, how are you doing today? Asking the child, how is your mental health? How are you adjusting in school? Making sure that the mental health side of children with chronic diseases is cared for as much as their physical health. We're just writing up early pilot data from this from this project, and so far the results are really promising. We hope to publish them in the next year or so. But again, the engagement level of pediatricians in this has been outstanding. So what does the future of Part 4 look like, and how do we continue to make it more applicable for people? So we want to make it easier to get credit if you're already doing the work. And that's the icon on the left and the icon on your upper right. And then we want to grow a program so more meaningfully things count. I'll start with growing a program. What I always know as a pediatrician, but we never really reflected in our program, and it became much more obvious during COVID, was the amount of time pediatricians spend advocating for health in their communities, going out to their communities and understanding where the gaps in care are and closing those gaps, recognizing there's food insecurity and working to open up food pantries, recognizing that there's a mental health problem and working on some sort of screening in a school-based system. And so starting next year, there's going to be a new pathway for community health initiatives to give credit for pediatricians engaging in their communities, not just with traditional QI methodology, but getting boots on the ground work. And we're looking forward to launching that in the first quarter of next year. Then the other, though, is to fuel collaboration. The improvement work happens locally. If you're doing that work locally, like the American Board of Pediatrics should accept that local work. And we do it through this idea of portfolio sponsorship. So I just want to just first say congratulations again to the Mercer University School of Medicine and the Georgia Rural Health Innovation Center. You have become our 103rd portfolio sponsor organization. So welcome as a partner. You didn't know you were partners with the American Board of Pediatrics, to a wonderful group of 103 organizations that partner with us to improve child health. This is a picture from a conference. We host a conference once a year. We invite portfolio sponsors up to the Chapel Hill, get to know us and present posters and share work. So we partner together. So what is a portfolio sponsor organization? It's organizations that can evaluate their own QI projects against kind of standards and approve those projects locally, and then award credit to engaged physicians. And so the whole process of getting your MOC Part 4 credit can happen outside the walls of the American Board of Pediatrics. It can happen locally. And that's the goal, because improvement work and the work you're doing in your community happens right here. This is the growth of the portfolio sponsor organizations over the last 5 years. The biggest emphasis since I started about 5 years ago was expanding it outside the walls of children's hospitals. So early on, most of the portfolio sponsor organizations were children's hospitals. Over the last 5 years, we now have 3 or 4 large clinically integrated networks. There's 5 AAP state chapters, and we welcome you all to that group. So what's the data look like from our portfolio sponsor organizations? So in 2022, if you look at Part 4 or QI completions, excluding kind of some online modules that we host, so this is just the work happening where somebody's submitting an application somewhere to get credit for it. ABP portfolio completions, and completions, we say completions, it's not necessarily physicians. One physician could have submitted 2 projects. So 6,037. The American Board of Medical Specialties has a multi-specialty portfolio, which actually approves it for almost any medical specialty, and we partner with them as well, so another 3,400 through them. And then all other completions were up and around 96, 76. And over the last 15 years, the data looks pretty similar. So about 50% of pediatricians doing QI work are getting credit in their local environment, not through the American Board of Pediatrics, but peripherally. And so we encourage you to use this to the best of your ability. You should never have to submit your work to us again. It all happens through your local organizations. And then just to give an example of 2 longstanding portfolio sponsors, Nemours Children's became a portfolio sponsor in 2010. They've since approved 72 projects and over 1,000 completions. And then Lurie Children's as well, 68 projects and over 1,000 completions. So again, we're really proud of these relationships, and it's some of the best work, most exciting work that we do is partnering with these organizations. So what are the benefits we hope you all get from this new designation? We hope that you can align your local efforts to improve care and the credit for those who are participating in that care. Integrating quality improvement into practice. So once this idea kind of starts to take hold, we hope that quality improvement becomes part and parcel of what happens in practice, because there's a set of resources available and time spent to drive care. And we hope there's organization at the community level. Community identifies a gap in depression screening, suicide screening, and the community can tackle that together. The group can get credit for it together, and it's not an individual practice based. You actually can drive care in your community. We've seen that happen time and time again. We hope, again, that it sparks interest in quality improvement in a way that drives the natural intrinsic motivation pediatricians feel to provide outstanding care. I don't believe quality improvement is a not popular standard at times because pediatricians don't care about the improvement of their patients. I think it's a not popular standard because it can be cumbersome to achieve. The goal is to make it easier to achieve. And at least I'll say this goes back 15 years, but when I first started getting involved in quality improvement, I didn't know what quality improvement was. I had the foggiest idea. And I found a career in it. But I didn't find a career in it because it was academically interesting. I found a career in it because I was passionate about improving the health care of kids. And I found a way to do that within the confines of what my job was. And I hope you all find that same passion, and you actually can find quality improvement as a vehicle to do what I know you want to do already. You can, again, mobilize a large group of people to make a difference and then minimize the cost and burden to pediatricians of getting that work counted in your continuing certification program. So I hope all of that is valuable to you all. And I'll just wrap up with this slide. If you ever need help as pediatricians, we also have a group of people that is always there and willing to help. This is just an example of a quote that we just got. They don't all look this wonderful. We get some bad quotes, but we do measure our customer service. We have about a 4.7 kind of satisfaction rating for our customer service work. But this is the most important thing. I put this quote up there is because it's the last line. Pediatricians take care of so many people. It's so nice when somebody really takes care of us. And that's our goal when you call for help. We want to help you through your careers. We have a responsibility as a certifying body, but we want to partner with you and uphold that responsibility. It doesn't have to be one or the other. So thank you so much for your time today. It's a pleasure to be here, and I'm happy to answer any questions that any of you might have.
Good morning, everybody, and good morning, Dr. Glenda. Real quick, I would just have a question.
Sure.
Specifically in pediatrics, what are some challenges that you face outside in the community, whether it be just health disparities? I remember you talked about outreach in the community or things of that nature. What are some challenges that you face, and what are some things, honestly, that you wish that the community could be more engaged? Because I understand that you're only just one person, and it's a group collective effort. So what are some things with your expertise that what you would recommend or challenges?
Yeah, I think that's a great question. Thank you so much. I would say probably the biggest challenge right now facing the field is the mental health crisis and the fact that the training environment that many of us went through didn't necessarily teach us how to care for patients with mental health in the communities that we're providing care. The training, again, for those of you that are not pediatricians, the training for many years is often based in the hospital setting, critical care time, and the behavior mental health component of that training is small. Yet you go out into the community and 25 to 50% of what you see, depending on the practice, has a behavior mental health component to it. So I would say one of the biggest crises we're facing right now is in that field. We recently did a study that looked at the competencies of people graduating, and in a way that wasn't tied to their certification, tried to assess the competencies of people graduating and their skills to provide behavior mental health to the community, and less than 50% of residents are graduating with what they perceive as the competency to do that work independently. So that's one. And I think that is true, and it's disproportionately impacts underrepresented minorities. So I think there's an impact across the entire field of pediatrics, and I think there's a disproportional impact to underrepresented minorities. You asked specifically about issues with disparities. So I think that's probably the biggest crisis we face right now. And if I had to pick one thing, that'd probably be it.
Thank you for your presentation. What's the ABP doing with regard to recruiting young women and young men to pediatrics as a specialty?
Yeah. Fantastic. So I don't have a great answer to that question. I will say it's a wonderful question, and it's one we're pondering. So the National Academies of Sciences, Arts, and Medicine just released a 50-page kind of consensus paper on the pediatric workforce about a month ago. And the conclusion in that paper was that there's a workforce problem in general pediatrics, but also in a ton of pediatric subspecialties. About half of the pediatric subspecialties, there's a significant workforce problem, and they are tied to the pediatric specialties, which pay less, unfortunately. The pipeline going into so the answer, people often look to us and say, "What's the answer?" And a portion of that paper asked the American Board of Pediatrics and the Accreditation Council for Graduate Medical Education, the group that oversees training programs, to shorten fellowships. One of the considerations was should you shorten fellowships to 2 years? The answer is we should consider that. We should think about the pros and the cons, and we're in the process of vetting that with a lot of people. But I'm not sure shortening fellowships to 2 years is going to solve the workforce problem. I think it might solve other problems. We might enhance the recruitment from people who are tons of money in debt if you shorten fellowships, but I don't think it's going to magically solve a workforce problem. So when we look at the information that we have, the pipeline coming in, so your question is perfect, because the pipeline coming into pediatrics is flat or decrease over the last bunch of years. And so there's no way to increase, for me anyway. We could tweak the numbers of years of fellowship, but if the pool coming in is exactly the same, you're just shifting from one to another. Somebody might be going from one fellowship into another, or from general pediatrics into a subspecialty. It's not changing the overall paradigm of the workforce. The American Board of Pediatrics hasn't traditionally worked or partnered with medical schools. It's the certifying body. We partner with training programs, but you're already in pediatrics there. We partner with pediatricians, but they're already in the field. And so a question on our mind now, I don't have the answer yet, is how does the American Board of Pediatrics work better within the field of pediatrics, the house of pediatrics, to begin to drive interest in the field earlier? And if we can do that, we then have to increase training programs and think about length. And we have to do all of this in conjunction. But I'm not sure any of it matters if we don't increase the pipeline, because then we're just shifting the chairs around on the deck as opposed to actually changing the true workforce dynamic. So your point is very well taken. It's the approach we need to take. It's just not a place we've gotten to in the past. So thank you. Yeah.
Thank you. Hey, I'm Dr. Odegaard, Family Medicine. I was just wondering, with the recent sort of increased push towards pediatric hospital medicine as a required fellowship training, do you think that from the perspective of the Board of Pediatrics, that has increased the quality of care or reduced the access of care in rural healthcare situations where fellowship training may not necessarily be a feasible option?
Yeah, great question. And so again, I'll just give a brief amount of background. You go back 5 years ago, and you graduated from a general pediatric residency, and you could practice without fellowship training in hospital settings or primary care settings. You can still do that, but there is a fellowship pathway now for hospital medicine, and subsequently a board certification option for hospital medicine. And the concern in the communities is that as that unfolds, will hospitals require those doing fellowship to staff hospitals, and might that decrease the access in the rural environment? So the short answer is we don't know yet. So the push to have hospital medicine as a subspecialty came from hospitalists. It was so the American Board of Pediatrics we have a stake in who we certify, but anybody new it never comes from us. It's proposed by the discipline, and it was a discipline that was felt very strongly that board certification was critical. And since that time, there's been a lot of question at the discipline level, not just with the American Board of Pediatrics. Like, was this the right thing to do? And some of it gets down to the questions that you're asking. I'll say we don't know the answers yet to whether or not outcomes are better. we don't believe there's been any impact yet, at least kind of networking with local communities. There's still plenty of people that are being hired to do hospital-based medicine without fellowships. We believe that's going to continue, but there's no way to know for sure. So I think it's too early on in the journey to reflect on that yet. I think we're 2 years into certifying hospitalists now, 3 years into certifying hospitalists. But great question, and one that we'll keep an eye on.
Dr. Weeks, I'm family medicine also. My question was specifically related to the practice of pediatrics in rural settings. Pediatricians in and of themselves, while they usually are the lead of that, are not the only people caring for pediatric patients. Family medicine, nurse practitioners, yep. PAs. In regards to the fourth section and quality improvement, is there an avenue or a way that those pediatricians can work with nurse practitioners, family medicine doctors, and we all get credit for the QI we all get credit for that QI work. I have to do that for my boards. I know nurse practitioners and PAs probably have something similar. Is there any way under the way you have it set up that yep. they can work together? Yeah, absolutely. So a couple of things. So one is the American Board of Family Medicine does participate in it's called the American Board of Medical Specialties multi-specialty portfolio. That's not the portfolio that this was approved as a pediatric portfolio. I'm actually traveling to Lexington next week to chat with my colleagues at the American Board of Family Medicine. I'm going to mention this example and see if I don't know if they'd be willing to accept pediatric portfolio designation for their projects, or if there's a way to do that. But we partner with them a ton, and I will ask them that question. But happy to take a card or get your number and name and reconnect with you. But the other is they do have a lot of pediatric kind of credit modules that exist, and there's likely a lot of overlap that's possible in between. But I will take your question to them, and I'll see them, I think, Thursday and Friday of next week, or the week after, first week in November. Great. And I'll find you after that lunch, and we'll exchange numbers. Thank you. Okay, here's a real softball. Is Riley Leonard healthy, and can Duke beat Louisville? I'll say Riley Leonard does not look healthy. Apparently they say he's healthy, but he looks a little bit hobbled. And I don't know enough about Louisville football to know if Duke can beat Louisville, but since I live in the area, I'll say absolutely yes.
Thanks for coming. I'm also family medicine. Great. And so I was going to ask the question before you said you were going to meet your colleagues next week, is what is the American Board of Pediatrics doing? Are you collaborating with the AAFP in any way on some of these grand projects, and which ones? Yep. And then definitely, I agree with you, mental health crisis is the biggest thing that I face in rural medicine. And are you guys working together with AFP and the pediatric boards to address that issue, and how?
Yep. So I would say some of my best colleagues in the boards community exist at the American Board of Family Medicine. So we chat all the time. Their current CEO, a guy named Warren Newton, was the chair at UNC for a number of years, so we knew him locally. So the answer is yes, we collaborate with them all the time. We probably chat once a month and visit each other probably once a year. The collaboration extends several ways, but one is just the simple platform that we host activities on, we share. And so if they have an activity that we like, they just give it to us. And vice versa, if we have an activity that they like, we can give it to them. And so there's the ability to collaborate relatively easily that way. I like the idea of the ability to potentially get this portfolio sponsorship going in a way that allows family medicine docs in communities like this that are working with hand in hand with pediatricians to get credit for the community-based QI work that's happening. Because that, again, makes it seamless. And we'll see if that exists or is a possibility for them. And I'll follow up there. Great. Again, thank you all for welcoming me today, and I look forward to chatting with some of you over lunch in the breaks.
Well, certainly, Dr. Mann, we thank you so very much. We have a small token of appreciation for you, and that was presented by Ms. Lauren Brooker. Lauren is one of our Children's Healthcare of Atlanta scholars from this 2023 cohort. So thank you so much very, very much again. At this time, we are quite privileged to have some remarks given by our very own Dean of the School of Medicine, Dean Jean Sumner. Dean Sumner is a member of the School of Medicine's first graduating class and is a former physician who has practiced in Washington and Johnson counties. She has led the way in a number of significant initiatives here at the School of Medicine and beyond, including a major telehealth initiative that is a component of our Children's Healthcare of Atlanta partnership. She's a 1986 graduate of the School of Medicine. She has served in an array of different positions here at the School of Medicine, including community faculty preceptor, professor, and most importantly, our dean. At this time, Dean Sumner, if you would come to present on the importance of rural pediatric care.
Thank you, and thank you, Dr. Williamson. And I am so happy to be here. I know many of you, and so I'm probably not going to say anything that you haven't heard me say 100 times. Rural medicine is really important, and really good doctors and nurse practitioners and PAs practice in rural communities. And I spent my life there. I believe in it. I've watched the miracles that happen in small towns, and Mercer is a school committed to rural health. The most underserved population in terms of people who come to medical school are young people who grew up rural. The average across the country is 4.3%. We approach 50% of the students who are rural. And that, I think, is one of the highest in the nation. We have 70% outside of metropolitan Atlanta. Now, we love Atlanta, but people who grew up in Buckhead are not going to Hayhira. So we really focus on our mission. There's a science to rural health that's often overlooked in academia. You have to have a broad range of skills. You see amazing things that walk in your office that people often in tertiary care centers see after they've been through several levels of care. So you are so valuable to the outcomes of this state, and we appreciate you. We're here to help you. I noticed they gave me the topic of how badly we need pediatricians, and I'm an internist, but I'll be the first to testify. We need pediatricians. Georgia has 120 rural counties. 63 of those do not have pediatricians. And the counties that do have a pediatrician, I don't know any that have too many pediatricians. Family medicine is critically important to the care of children as well. So we appreciate you guys being here and taking part. We're trying to build a system of care. Now, through our relationship, we're extremely honored to have a partnership with Children's Healthcare of Atlanta. And it is a 10-year commitment. And many of you have already been approached to be part of that initiative. And it includes not only improving emergency care for pediatricians and giving opportunities in physicians' offices to consult with a tertiary care center or even a pediatrician in the next county. If you're a family medicine, you want to get a pediatric opinion, you can consult through high-quality telehealth because you can actually examine the patient, look at high-resolution cameras. We do mental health. We've done a pilot and a pre-pilot in 2 counties that we finished this summer, and we'll go into a full pilot on mental health screening. We have the potential for an autism project working with Children's and Marcus Autism Center soon that will come into a rural county, which is an amazing center. And then we also, through the generosity of Children's Healthcare, last year we started the Children's Scholars. Lauren, of course, is one of those 10. We have 10 free rides, full scholarships for 10 pediatricians every year for 10 years. That will live and work and practice in a rural community. In Georgia, that's a county of less than 50,000. This year, Children's has announced they will have 10 scholarships for family therapists who will work with those communities and live and work in there to provide care for children in those communities and their families, which I think is a game changer. I think that this project allows us to transform rural Georgia. But the secret sauce is you guys. We want to work with you. You're doing the work. I've been out there doing the work. It is hard. I can tell you 1,000 stories. I will not bore you. But people who don't understand the importance of your presence in these counties need to come and see your work, because you save lives and you prevent illness. And care is transitioning to communities. You see that certainly in adults. When I was a student, you stayed in the hospital 2 weeks if you had heart surgery, or 3. You stayed in there 10 days for your gallbladder surgery. Now you hardly stay 10 minutes. And who takes care of you when you get home? Your local doctor. And the patient, you say, who took care of you in the hospital? And a lot of times they go, I don't have any clue. A lot of people came in. We don't know. So we've got to improve that system. We need community-based care. And these rural communities are vital to Georgia. You produce the wood, the fiber, the vegetables, the corn, the thing that feed Atlanta and the rest of the world. And so industry does not come to areas without health care. You will never break the cycle of intergenerational poverty without good schools and good health care. And good health care brings good schools. It brings better performance. Pediatricians and family medicine doctors who really take care of children are so important. There's a proverb that you've all heard: you raise up a child in the way he should go, and he will not depart from that. I don't think the Lord was talking about pediatricians when he did that, but I think of that often. If you start them out right, even the most uneducated family, or the dysfunctional family, or the poorest family, cares about their children. Mothers care about their children. Daddies care about their children. If you can get them to understand what that child needs, you motivate the family to do better, and the family does better, and there are huge ramifications across the whole spectrum. So I'm here just to say thank you. We're really proud to be a portfolio site. We'd love to partner with y'all on figuring out how to integrate some of these projects, because there's no way that you can have enough pediatricians in rural Georgia, and there's no way you're going to have enough family medicine doctors, really. Mercer has lots of, we're completely devoted to our mission. Most of you know we get funding from the state of Georgia, and we're an NIH Center of Excellence in Rural Health. If there's a way that the school can work with you, your practice, or the center, which I think of us as one and the same. Glenda's going to get me for doing that. But the center was placed here by the state because of our mission. We take that mission very seriously. And when we call, and I've been in rural Georgia, when people call and say, we're here to help you, and you go, yeah, right. Where are you calling from? So I get the opportunity to call people around the state this week, and some people call back. Because you know somebody that knows somebody that gets them to call you back. When we come into your community, we're not there to replace you. We're not there to bring some industry to take away your business. We're there to help you survive and help you get the things you need. So please feel free to reach out to us, the center. We're there to help. We appreciate your being here today. We are deeply honored by our partnership with Children's. Deeply honored. And I can tell you, we are 1,000% committed to raising the care for children in this state. I don't know how many of you read the Wall Street Journal. I get it occasionally. My campus dean here brings me his paper copy that he told me the other day was going away, so I don't get a free paper anymore. But there was an article on the front page of the Wall Street Journal about the ER care for children in this country. I'm an internist, so you have to consider that I don't know all that data for sure. But when I read through that article and then read some of the responses to that article, this children's project is ahead of that curve. We've been laying a groundwork for the last year, and you're about to see it expand. This year we'll add more hospitals, more pediatricians, more mental health services. So please let us know how we can help you. And we would love to work with you. So thank you for being here, Dr. Mann. I enjoyed your presentation very much, and we're glad to host you. And if you have any problems or needs, let me know. Thank you.
Our next presentation will be offered by two co-presenters. First, Dr. Catherine Cheek. Okay. Thank you. Dr. Catherine Cheek, who has worked in private practice since 1986 as a pediatrician in Columbus, Georgia at Rivertown Pediatrics. She also has served as a pediatric faculty member with the Medical Center of Columbus, Georgia, clinical associate professor in pediatrics at Medical College of Georgia in Augusta, as well as clinical assistant professor in pediatrics here at Mercer University School of Medicine. And Dr. Cheek serves on boards of the American Board of Pediatrics, a fellow for the American Academy of Pediatrics, voluntary recertification with the American Board of Pediatrics, and also maintenance of certification with the American Board of Pediatrics. She completed her Doctor of Medicine degree at Medical College of Georgia, completed her Master's of Health Education at Medical College of Georgia, and then also her Bachelor's of Science at the University of North Carolina. Our second speaker is Dr. Denise Hines. Dr. Denise Hines is an award-winning, nationally recognized expert in healthcare technology. She has more than 2 decades of healthcare experience in a variety of settings, including health systems, physician offices, home health, technology vendors, consulting, state government, and revenue management. As the Chief Americas Officer for HIMSS from January 2019 to July 2021, she had direct oversight over a business unit responsible for generating annual revenue in excess of $50 million through professional development, member services, conferences, and events. She also served as executive director for the HIMSS Foundation and led initiatives on women in HIT and global health equity. Since its founding in 2013, Dr. Hines has served as executive director of the Georgia Health Information Network, which is the state-designated health information exchange. Her firm, eHealth Services Group, is contracted by Georgia HIN, which is the Georgia Health Information Network, to provide the staffing needed to support the nonprofit's mission and activities. Dr. Hines has been instrumental in advancing healthcare connectivity in Georgia, ensuring physicians have the information they need to deliver quality care. Through her work at the local, state, and regional level, Dr. Hines has improved technology adoption and advanced its exchange. In 2017, she was recognized with the prestigious Women of the Year in Technology Small Enterprise Award from Georgia's Women in Technology. Ladies and gentlemen, Dr. Catherine Cheek and Dr. Denise Hines.
Okay, thank you so much. First of all, this is the first time I'm Dr. Cheek. First time I've been to Mercer, to this campus, and to see your beautiful facility. So I'm so appreciative to be surrounded by all these beautiful Penleys. I really feel very lucky to be here today. Just want to tell you, though, that I'm sort of the teaser. I know you've all been to concerts before, and they kind of have the little, the person that's up front that's just playing the guitar on the stage, and then the big band comes. So I'm just here to just give you a little bit of tease about technology and how technology can help your practice and, make things better in your life easier. So really, life just got easier. Do want to say that I have nothing to disclose, and the applications and the apps are freely out there on the internet, but I don't endorse them. I'm not selling their products or telling you for sure. Just like you check out any other app, if you choose to download any of the things I'm suggesting, I suggest you take a real good look at it. So with that, we'll get started. And first of all, let's see. Oh, I went backwards. There we go. We have some objectives. I'm going to show you the beginnings of ChatGPT, how it got started. I'm going to talk about some of the possibilities in medicine and demonstrate some apps that really may help you in your day-to-day work. So first of all, I got to keep going in the right direction. Okay. Does anybody here use ChatGPT? Have you ever used it? Raise your hands. A few. So good news, artificial intelligence is here to stay. You will be using it if you're not using it already. Definitely within the next year or two, probably after you see this talk, maybe within the next day or two. It basically started in the 50s, and Mr. Turing said, once a machine gets to the place that it can have a conversation like you and I, then it's an intelligent machine. And you see how things have transitioned through the years. Things went sort of slow. They did all kinds of improvements. Really, the most exciting thing has occurred since the 2018, 2019. We're talking about just a few years ago. And basically, GPT number 1 came out, and then 2, 3, 4 more editions. It continues to fine tune, and you'll hear about artificial intelligence. You'll hear and read in the papers all kinds of concerns about social and ethical problems that can be associated with this, misinformation. OpenAI is the company that makes ChatGPT, and really it has transformed the way lots of information is documented and exchanged, and things are created. It's exciting, it's unbelievable, and once you see it in use, you will just go, wow. But we will all need to make sure that it is used professionally and, ethically going forward. How can we use it, and how is it being used already today? And how can it make your life easier? Medical information retrieval, clinical documentations. I don't know if you have to document in your office, but they're already coming out with projects that can document the whole conversation, everything that's going on in your office, and they summarize it as a SOAP note, and it pops in your computer. Patient education. You can print all kinds of information in just a second about whatever you want to give education on. You can have a symptom checker and, triage, and tells you the kid shows up with a purple rash or a red rash that's on his face. It'll give you all kinds of opportunities to look through. And if you're in a hospitalist, it gives you all kinds of algorithms of where to start your treatment. So that's out there. It's certainly going to be used in medical training. The machine will ask the medical student questions and generate possibilities for them and to get them to interact. You don't even have to have a fake patient. It's just right there in front of you with just a computer. Telemedicine support. So if you've never tried it, don't miss out. The first ChatGPT is out there on the App Store. It's free. The free version, you have to know that the information stops in 2021. So, if something happened after that, say who won the World Series last year, it's not going to know that. There is a paid version where you can get that much information, but the free version is kind of interesting. If you want to know who was the first pediatrician in the world, something like that, or if you want to know anything more technical than that, you can ask all that. So anyway, don't miss out. ChatGPT, you just download it, okay? I want to mention Doximity. Has anybody ever used that? Know what that is? I don't know how you use it. Some people, just see it to view their colleagues. Some people use it to get medical information about news that's going. Myself, I use it to call patients because you can call the patients. It doesn't reveal your phone number. It allows you to send them a text if they don't answer. And then if you've had a discussion with them, it allows me to text them and say, I've sent your medication over, or here's the information that I wanted to give you on roseola, and it pops up on their messages. That's the way I use it the most, but it is most recently added a Docs GPT component. And if you'll see right on, I don't have a pointer, but you'll see right on across the top, it says Docs GPT. And so this can be very helpful to you. And I'm going to show you some ways. Examples say, if I need to write a letter to get Social Security benefits, I can do that and help support that for my patient. If I wanted to go ahead and write asthma care instructions for my 8-year-old patient in the method of Dr. Seuss, I can make that happen. If I want to write a letter to Cigna to say, why in the world did you not agree to getting this patient this treatment, I can do that, okay? It is a HIPAA compliant app. In other words, everything is definitely, when you transmit back and forth to your patient, is HIPAA compliant. They have actually where you can do a video phone call, and so you don't have to have a special app to do a video teleconference with your patient. You can switch right over from just a phone conversation to a video conversation. That's really nice. It's all trained in medical technology and terminology and abbreviations. So when I say CBC, it knows what I'm talking about. And it makes it easier, and it's fluent in dozens of languages. So if I've got a Spanish speaking patient and I need to tell them, okay, I'm going to give you the handout on measles or roseola, but translate it into Spanish, it does it like that. Okay, occasionally it does generate wrong information, and that's what I'm talking about. You want to make sure that you read, just like anything else, what you're getting ready to send to the patient. It's taking information from databases. I think it said 175 billion sources, and I'm sure it's more than that now. That was probably last week. There is wrong information in there, but there is a lot of right information in there, and so you need to look at it closely. And of course, on the free one, it stops at 2021. So here's just an example of the Dr. Seuss letter. I hope you can read it. In a house with a mouse under a tree, if you have aspirin, your specialty will see. But don't you worry, don't you fret. We have some tips you won't forget, and it tells you how to take your inhaler and your control of medicine and all that, and the messages of Dr. Seuss, which is fascinating. Okay, so I want to, let's see here. I'm going to get my assistant to come help me, because I want to just let you see it in live and work and just see how fast this happens. We hope this is going to work and how technology. If it doesn't, I have a backup plan.
Oh, good.
And this is my profile on Doximity. And remember, I have no allegiance to Doximity. I just use it. It's been helpful in my practice.
So then we had typed in something.
Where is it? On here?
We can see if there's anything else open. Yep.
Right there.
Okay. You're going to have to type it.
Okay.
Okay. So normally in my practice, I'm getting her to type this because this.
Oh, I need your
Oh yeah. This computer doesn't have the voice activation. I use voice all the time and dictate. I'm sure probably many of you do too, to talk to my computer and get to do whatever. But this computer didn't have that. So normally I would just sit there. I would click on the Docs GPT, and then it says Catherine, and it's got a little microphone, and I say whatever question I'm going to say. And she's putting that question in right now. So I'm telling you what I would normally, this is how I did it last night. I wrote this. I said, write a letter to Blue Cross Blue Shield of Georgia requesting reconsideration of a denial for my patient, Alex Cox. She's 2 years old, and since she's only 2 years old, she needs a CT of the head, not an MRI of the head, because we really don't need all that sedation that it would require to get her the MRI. I really can get the information I need just from the CT. So I've asked Blue Cross for Docs GPT to write me a letter to Blue Cross Blue Shield to get this. Okay, and normally I said I would, and so.
Okay, now hold on one sec.
You got to.
Now we're going to put that over here.
It's writing the letter right now, and he's got to get this to go up there. Watch this.
Yeah. Thank you. Yeah, so we just typed it in, right? And then you hit
just type in what I said. Normally I dictate it.
enter, and then
And enter, and here's what's coming out.
who knew?
Wow. So I want you to see it live and in person. So that's the teaser. Like I said, I'm the teaser. If you have more questions about any of this, you can ask me later. But go back to my presentation. We are now on to real technology in Georgia, something that's really happening. And let me say about my friend, Dr. Denise Hines, that's coming up here. We've worked together a lot for projects. I use GHAN, not every day in my practice, but I have a lot of foster care patients, and I've been passionate about trying to get the information that I need from them. And I've worked with her and GHAN and had some very positive examples of things that GHAN has made a real difference in being able to locate information on these patients. So that's my beginning. Like I said, I'm the teaser. This is the real deal that you came to listen to today.
Thank you, Dr. Cheek. And I can tell you Dr. Cheek is the strongest advocate I know of ever in my experience in healthcare. She is advocating with every commissioner, every partner, everyone that is interested in learning more about how to improve healthcare for children. So we meet every month at 7:30 a.m. And we are there talking about technology and working together to improve healthcare for children. So thank you for having me. I did graduate from Mercer University in Atlanta with my master's degree in the late 90s. So I won't stop there. So as Dr. Cheek mentioned, the Georgia Health Information Exchange is your Georgia Health Information Exchange. It is the statewide health information exchange network for our state. It is state designated by the governor's office and funded specifically through the Georgia Department of Community Health, among other agencies, as well as federal grants through the Office of the National Coordinator. And we most recently received $1 million from the USDA to help improve connectivity in rural areas. So we're working with several of our community-based organizations in rural areas. So to give you a sense of what we do, we are here to connect all related stakeholders in healthcare. We started with a group of people who had a vested interest in making sure that everyone at a table who is interested in taking care of a patient could see the same information, could have health information at their fingertips in order to provide care. So our goal is to provide health information to providers and stakeholders across the entire state. So this model tells you, or what you can see, state agencies, we have ambulances, payers, public health, health systems. In the purple, we have providers. We're connected to the national network. If you're not familiar, we've been building a national network that says if Denise Hines moves from Georgia and I move to Florida or Alabama, North Carolina, my health information should follow me wherever I go. So Georgia's information exchange is connected to the national network so that health information can follow that patient everywhere they go. So you are fortunate to live in a state where your health information exchange network is an award-winning network. We've been up and running for over 10 years, and we have documented achievements. We've exchanged over 20 million continuity of care documents, care records, medical records, PDF forms of care throughout our state and our providers and the national network. We also exchange securely messages for providers who do not have ways to submit through an electronic health record. We give them technology to securely attach documents and exchange information that way. Now you can see we've grown dramatically over the last couple of years because just in 1 year, we've exchanged nearly 20 million just this year. And I'm going to talk about the dramatic growth we've had just in the last year. And then we average around 1.2 million messages among providers every year. And these tools that I'm describing today are available to Georgia providers at no charge from GHIN. And I have to put that disclaimer because sometimes technology vendors will charge for interfaces, user licenses, but GHIN does not charge our healthcare providers. So let me talk a little bit about how many people we have connected and what we connect to. Hopefully you'll see some of the nationally recognized hospitals. CHOA is definitely on there. Piedmont, Northside. So the facilities that you're familiar with should be up here on the screen. I want to talk a little bit about the state agencies because we have really taken a tremendous amount of resources and time to connect the state agencies. So if you query our state health information exchange network, you're going to get information from DCH, claims data. you're going to get information from public health immunization data. More importantly, in the work we're doing with Dr. Cheek is we've connected DFACS. DFACS needs to see information, health information on the children in their care. We also provide them with alerts. So if one of the children in their care presents to a hospital, we send them an alert. So a child has presented to Children's Healthcare of Atlanta. An alert goes back to DFACS to say, hey, one of your kids just presented in the hospital. Get on the phone, send an alert or call, or they can query and take a look at that record and make sure that they understand what's going on. We've been talking about behavioral health. We've taken the time to meet with several attorneys to work through the HIPAA requirements about connecting and sending health information. We have the inpatient facilities from the state agency from Behavioral Health connected. So if there are double consented, because that's the rule with behavioral health, there's double consented health information available to us, we're going to send it. Double consented means that the patient in this instance with behavioral health has to consent to send it to our network. In other cases, everyone's in unless they say, take me out. Behavioral health right now with all the laws say we have to get consent to put them in first. We're working, and this is something Dr. Cheek and I and PHIC are advocating for. Can we do something around those behavioral health rules to help us and providers receive behavioral health information at their fingertips when needed? So that's something Dr. Cheek is helping us advocate for. We also have rural hospitals, and we also have correctional facilities, federally qualified health centers, and CMOs. If you're a pediatrician in Georgia, you're probably going to encounter one of the care management organizations through DCH. They have the ability to work with you through GHIN to see immunization information, along with working to see provide claims information, along with receiving a service that tells them that members have moved from plan to plan. So we provide them with that tool as well. And then our rural hospitals and critical access hospitals. So I mentioned we are connected to the national network. And again, that provides us the ability to communicate with other statewide exchanges or other organizations on the national network. So if I leave Georgia and go to North Carolina, my health information can be there. We also communicate with nationally recognized providers who may not, who have a presence here in Georgia, but also a national presence. So your CVS's or your Kaisers, your Walgreens coming on. So we are looking to make sure that anyone who has presence in Georgia, healthcare presence, can get health information. We also are connected to the federal exchange, so the VA, Veterans Hospitals, Department of Defense. They have information in the network and partnered with Wellstar and Grady and Emory. Their health information is in the network and available to providers. So let me talk a little bit about services, because it's not just about moving documents. We also do, again, I mentioned we're on the national network. Now, I can say that we also participate in creating standards, because one document is not one document that is equal. We have to work with these federal committees to make sure that we can get discrete data. So if a document or if a data field has name, let's take something very simple, and I'm sure all of you have seen this. Denise Hines could be Denise Hines, Hines. I could be Heinz Ketchup. I could be D. Hines. I could be Dennis Hines. And somewhere along those lines, the matching has to happen. So we work on matching through our master patient index. And the more facilities that are added to these connections, the more likelihood or more complex a matching becomes required. So we work with Dr. Cheek and other pediatricians to help us with crossover sessions. So let's say, for instance, we have a Denise Hines, and let's say I'm 10 years old. I go from Children's Healthcare of Atlanta to Grady, to Dr. Cheek's office, to get my immunization done, to health department. I could be 5 different names throughout that process. So we work with our pediatricians to help go in and, as they are authorized to do, query to see if they see all of the stop points that I had, so we can confirm that data is correct, matching is happening as it should, and that the pediatrician can see all the authorized documents that they should be able to see. So that's something else we do with Dr. Cheek's assistance. So we meet our providers where they are. So for example, some of our providers still don't have electronic health records. We understand that, and some, for example, long-term care, most are coming on board with technology, but may not have it. Ambulances, dentist offices, most are still implementing technology. So what we do is we offer just a basic service. Can you get Wi-Fi? If the answer is yes, we start there. So we offer what we call secure messaging. Looks just like email. They can upload a PDF, Word document, and exchange securely information with their care coordination teams or anyone else that needs to receive that. And we set that up and send and receive millions of messages per year. So these are usually those outliers that have not adopted technology. Then this is where most of you will probably end up seeing data from the exchange, query and retrieve. So if you go in, Children's Healthcare of Atlanta uses the EPIC system. You go in, Denise Hines has presented. Query for Denise Hines. In the background, Cho is connected to GHIN. Cho is connected to GHIN, and GHIN is searching every connection we have, looking for everything we have on Denise Hines. We're going to present that back to CHOA. And CHOA is going to organize it where it's viewable to their users. Dr. Cheek is connected to GHIN. She has a way to see the information as well. So what we are doing now is, this is a longitudinal record view. We're bringing everything now in discrete data so we can put it in a longitudinal view for you. So you're going to see medications, allergies, problems, alerts if you have them, all in one longitudinal record. And it's going to show you, and you can drill down if you want, or you can sort it the way you want to, the way you use it. But for us, we're going to present this in a longitudinal view. And this is where we're trying to get to in healthcare. If we can get discrete data, match it up, put it in the right fields, we'll be able to put it in this view. And this screen shows that we have continuity of care records available for this person. We have immunization information. We have the 3231 form available. And the provider can pick something. You'll see in the red, it's has a high glucose report. So the provider is notified there and can drill down into that record if they would like to. They can also trend it. They can also see previous visits, tells you where the visit happened, dates, anything that needs to be flagged. So we put this together for our members. So then we can also provide, again, the graphing of labs. We can see growth charts. We can see weight charts available for our members. So this helps our providers who log in to see everything we've gathered. We can chart it and make sure it's available to all of you for use. ADTs work where if you're the provider on record, you want to be notified when one of your patients presents into a hospital. We can also notify on any kind of alert, If it's in the data, we can notify on it. So if you want to be notified that a specific medication has been prescribed to one of your patients, we can send you an alert. If you want to know one of your children has been presented in one of the hospitals, we can send you an alert. From there, you can decide if you want, what the appropriate medical actions are, but we set that up for our users. So patient can be admitted, discharged, or transferred, even held on observation or treated in the ER. And again, if it's in the data, we can alert or let you guys know there's something happening for your patient if that's what you would like to see. So that is the clinical side. I want to talk a little bit about the social care side. Now, in the data, we're going to get Z codes. If you're not familiar with Z codes, those are the codes associated with social determinants of health. We're starting to try and advocate for our healthcare providers to put that in the data. Race is hard to capture. Addresses, all the zip codes. So that social determinant of health data, education, comes in on the clinical side if it's captured by the clinician. So one of my favorite stories that I've learned through our pediatric group is, and Dr. Mann touched on it, the pediatrician serving as the community coordinator. So we're going to talk a little bit about community care and where that data is coming in. So we're hearing that our pediatricians have cross-trained their staff to understand where the community resources are and do screenings. So they're screening on, do you have a home? Do you have a caregiver? Do you want to go to high school? Do you have food to eat? And let's just say some of those answers are no. Our pediatricians are asking their staff to coordinate with the local community food banks, the Walmarts, the pharmacies to get vouchers. And so what happens is that community coordinator, who's also the office manager, is working to get on the phone and make phone calls to those local community-based organizations. So they call, get services, give the mom a voucher, but they never know if the mom goes to get the service. Give the voucher, mom goes home, child comes back a year later. They never know what happens with the mom unless that community care coordinator, which is their office manager, calls back. We have now added a way to capture that workflow. We call it closed loop referral processing. So we call it Georgia Unified. We've added where our pediatricians and users, clinicians, will be able to see clinical record, longitudinal record, claims, immunization, social care, and also any referrals made for that particular patient or child. So the way it works is the user, let's assume it's pediatrician or family medicine, would pick the referral process that they want. So let's say they're going to refer someone to the United Way. Patient sits there, they're in the patient record. They're going to launch out into this part of GHIN. They're going to pick the service they want. So United Way, connected on the back end, is part of GHIN, which is what we're working on now. The provider can also add their own screenings if they want to. That screening I just mentioned, they could add that into GHIN. If the answer is no, or if they want to trigger off of a yes answer, yes, I need services, it's going to trigger out and offer them the listing of available services in their area. So they get the directory, and then they can launch the referral. The tracking of the referral happens, and then the loop opens, meaning the loop goes over to the United Way. United Way receives it and says, hey, I've gotten something. They now launch into their process within the United Way to receive it, work the referral, and offer the referral back to the patient. Patient comes in person, gets the process or the service, United Way closes the loop. Patient showed up, got the service. So the social care provider has received the service, checked the location, did the fulfillment, closes the loop. All of that is now tracked in GHIN. So what you see with these workflows is how we set up a workflow. So we can call the United Way, we can call a CSB, CBO, community-based organization, and work with them on their workflow. So this works both ways. We can close a loop and or we can set up the process within their office. So if the United Way does not have anything, which we are talking about moving from healthcare providers who have been using EHRs for years to community-based organizations who are using Excel spreadsheets today. Most of them are. Some are now adopting technology. So we can offer them an instance of this. So if that same pediatrician always calls the one location in the United Way, we can go to the United Way and build their workflow to work directly with that pediatrician or others in that community. So this is what we're working on now. So everyone in that loop, from the pediatrician to the mom who can log in, to the United Way, to the office manager, can see what has happened with that patient. And we call that closing the loop for care. So that's what we're looking at for the future. So today we're still mastering or still onboarding healthcare systems, exchanges, agencies, CMOs, Medicaid providers through GAMIS. If you use GAMIS, you should have a launch into GHIN, which is coming soon. And then future social and community-based organizations. We talked a lot about behavioral health. CSBs there are 22 of them in the state of Georgia. We're in the process of making sure all of them can get to GHIN because the community-based organizations are now becoming even more important outside of the inpatient processing for healthcare. State social care programs, EMS, home care, all of these are now our new targets for bringing them into healthcare. So all of you will be able to see the longitudinal whole person record. You may be hearing that. We're calling it also the unified record when we bring in that social care referral process. So for you to get involved in GHIN, we are going to ask you when you call us, or if you say, hey, I've never seen anything, I need help. We're going to ask you what your needs are. We can help you with referrals, the longitudinal record, working with electronic case reporting that goes directly to CDC, immunizations with GRITS, and we also work with our providers on pilot programs. And so next steps, basically, reach out. If you don't have access to GHIN, let me know. I will make sure my team reaches you. If you're connected to a major health system and you use their electronic systems, you're probably getting information from GHIN in the background, or usually on another tab that says outside documents. Training, implementation. And so we are here as your statewide health information exchange network to support you. We also are connected to public health. You can submit to the birth defects registry. You get GRITS immunization information. We're connected to the Alzheimer's registries. So if you haven't heard of us, please let me know, and we'll be more than happy to make sure you get connected and or find out if you already are connected. So with that, Dr. Cheek, I'm going to call her back up, and we can take questions or see what we have. We did good.
thank you for this. It was really interesting to hear this and to talk about how the data is being collected in the background. My question is, even within our own healthcare system, patients get several charts because they have duplicate last names or things like that. Is there any talk in your world about developing like a nationwide or a universal level M number or ways to try to help with the matching process in the background?
Yeah, I could, from a national level, we have been advocating for a national patient identifier that hasn't gone far. We receive constant pushback on that. But as you can see in the example I gave, every time, like you mentioned, a patient presents, they're going to get a new medical record. So we at GHAN, we have these algorithms that do the matching. And when we find, and that's why we rely on some of our pediatricians and other providers to confirm that our matching is happening. It's complex algorithms, but we are still advocating for a national provider ID. You can Google that. It's been out there for 10 years and it doesn't get a lot of traction though. But the more organizations we add to the network, the need for you to have information from, let's just say, everyone at your table, it gets complex, and it's going to continue to get even more complex as we add and have the need to see the longitudinal record.
And I'm sure all of you are aware of the complexity of babies. We have so many babies that are born with a mother's name. And then, of course, some mothers have problems, and then DFACS intervenes, and that baby goes into DFACS. And the mother may change the name to another last name, and then it's now moved out of the address that it was at, that it was identified with. And so there's nothing that matches other than the birth date. Mm-hmm. And so, yes, there are complex algorithms and all kinds of systems because that baby got an immunization in the hospital. Mm-hmm. And that was the number one thing. And so I need to know that. But more than that, I also, as now the poor pediatrician that foster care child shows up in the office, I need to know what happened in the hospital. Mm-hmm. And so we have found ways to find it, but it is a challenge. It's a challenge from a public health, immunization. It's just a challenge.
Yeah. We also have, in our new capabilities, we can, for example, with DFACS, not require address if we can get other fields to allow them to search on. We get their roster, but also if, for example, Dr. Cheek is looking for a child who is in the DFACS roster, she's probably not going to have a good address. So we are working with the pediatricians, get that use case to our software developer to say, hey, in some instances, address just can't be a required field. We have to come up with other ways. Now, what Dr. Cheek will get if she does a search on Denise Hines and she doesn't have an address and she has maybe a date of birth, she might get 3 or 4 Denise Hines, and she's going to have to intelligently pick which one because we don't have an address to match on. But that's better than, what we have to work with, 2 years ago.
Yeah.
Oh, sorry.
I'm sure it's already complex enough trying to work within the state of Georgia. Is there any thought to, especially for immunizations, working with other states like Florida or Alabama? We get lots of kids that come from there. Parents don't know a previous address, especially if they're in foster care. Yeah. And we have trouble getting their previous shot records from those states.
So what we're doing is we're locally connected to the immunization registry, GRITS. Not sure who named that, but it's called GRITS. We're locally connected. So your local Georgia base, if it's in the immunization registry, you'll get it. We're also connected to the national network. What that will allow us to do is create a document that will flow, across state borders. We can also pull down if another state has an immunization record that is available, we will pull it down if the name matches. So that's the beauty of being on the national network, because all of us, meaning all the statewide exchanges and those standards on the national network, we all use the same standards. So we should be we should be able to pull down documents that go cross borders if it's available. So we constantly advocate for more people in healthcare to be on the networks, because if it's available, we can get it. If they're not on the network, it's not going to be there.
Is ConnectX EHR vendor agnostic, or do you have to have specific EHR vendors in order to be part of ConnectX?
It's vendor agnostic. We all use technology standards in the background to connect. So if you're using a off-the-shelf EHR vendor that's approved, I would say, by the EHR Association or something like that, we can connect through HL7 profiles. We can even take a flat file if we have to. It's not our favorite, but we can. We can.
Has this been implemented with defects yet?
Yes. So what we're doing now, literally right now, today, yesterday, is creating the longitudinal view for defects. They want, from pediatricians, they want all well care visits available to them. So for us, meaning GHIN, we need to get back to our pediatricians. So this is going to be my ask to Dr. Cheek. Can you help me get as many pediatricians contributing the well check visits to GHIN, because that helps DFACS. So DFACS will have the longitudinal view that I showed. They'll also at some point be interested in using the social care record, because children are referred out for many services. So DFACS will have longitudinal record. They have access to GHIN now. Their roster is built in GHIN. They also get ADT alerts on the children that move. If the hospitals are sending us discrete data, we can alert DFACS that a child has been admitted to one of the hospitals. They also want dental records. I'm not sure if we have that, which means GHIN will be advocating and looking for dentists who will come on board and help us build that DFACS record. So, but we meet with DFACS regularly, get their needs, build their use cases, and bring them back to Dr. Cheek. Dr. Cheek, we need help.
Hi.
Picture.
Hi, thank you both for your presentation. I'm Lakeisha King, one of the nurse practitioners here at Maconville Health Department. And I noticed you said that this was available through the Georgia Department of Public Health. So my question is this available for all public health departments? Is it a free thing that we can get access to? And if not, how can we access it?
Okay, so we provide access to the epidemiologists within the state agency. What we're waiting on from public health is for the public health district labs and offices to have electronic systems for us to connect to. We're still waiting on that project to get done. When that happens, we are ready to connect. But my understanding today is we're still waiting on the district offices to get connected. What we can do, we do have a solution, is bring you in on the social care side and let you get started. But I will work with the state informatics office to see what we can do. So let me make sure I get your card to see what we can do.
And one thing Dr. Hines brought up is that we're advocating on a state level from her agency and also from the pediatric mental health. As she talked about, there has to be, a two-step process in order to get mental health records, which we all know is a real big deal. But we are advocating that since the state essentially becomes the child's guardian, that the state, from the moment the child gets into a foster care, suddenly that consent is implied instantly. And so that will make it much easier to transfer information on foster care patients to providers at all levels, because the state can actually opt that child in if they would choose to do so. That may require some legal, and so we're kind of advocating at the legislative area for that as well too. Yes.
We have said this, but does this program, because it allows you to track referrals and kind of close the loop, when you use it in your, if we could get access with our EHR, does it tell you, like with different insurances, which providers are preferred, covered under different plans? I think that when we're trying to do referrals, that's always a question. It's a lot of background work to go into a specific plan and try to find who's covered and then send a referral to someone who doesn't take the insurance. So does this help with that?
It can. Today, excuse me, we do have a new project with Aetna. We just started. So what we're going to do is take the Aetna roster in the state of Georgia and help them build this for their members. We haven't yet developed the use case to put the insurance information with the services. So that will be something that will be available as a field and a workflow that we can develop, but we haven't gotten there yet. I'll take that down, put that in as one of our use cases. Okay.
Okay, thank you. Thank you. We're gonna get
I now would like to introduce our next presenter. Our next presenter is Erin Harlow Parker. She has worked in the field of child and adolescent psychiatry for 35 years. She received her BSN from Rhode Island College and her MSN from Northeastern University in Boston, Massachusetts. Her practice areas have included inpatient, outpatient, consult psychiatry, and behavioral and mental health illness prevention work. Erin is currently a manager of child advocacy programs, behavioral and mental health at Children's Healthcare of Atlanta. Her passions include suicide prevention, treating patients with eating disorders, and reducing mental health stigma. She is actively involved in state behavioral health initiatives to improve the behavioral health needs of children across Georgia. In 2018, she was awarded the Institute for Healthcare Improvement and National Patient Safety DAISY Award for Extraordinary Nurses. Ladies and gentlemen, Ms. Erin Harlow Parker.
Thank you, Kedrick, for that kind introduction. And it is truly an honor for me to come and talk to you all about something that is very near and dear to my heart, both professionally and personally. Before we get started, I'm really curious a little bit about who's in the audience. So I can guess some of it because I've heard you say what you are, but how many are pediatricians or family practice docs? Can you raise your hands? Okay. And how many are nurse practitioners or PAs? And how many students are in the room? 2. Okay, great. It's really helpful for me to have a good understanding of the audience I'm speaking to. So today we're going to talk about addressing suicide in the primary care setting, and really how we talk about it is going to be the biggest focus of that. I have nothing to disclose. And today, from an objective perspective, we're going to spend some time talking about the role that stigma plays in talking about suicide and how that gets in the way of that. Understanding things like risk factors, warning signs, and protective factors related to suicide. We'll talk about some evidence-based screening tools that are available to you and how to use some of them. And then really spend some time about how do we have these difficult conversations with kids and caregivers when a child screens positive for suicide or is talking about suicide, and understanding the role of safety planning and lethal means counseling. So let's start from a place of why are we even talking about suicide? Lay some foundations. So what we know is that 1 in 6 youth in the United States, ages 6 to 17, have some mental or behavioral health diagnosis, and this comes from the National Alliance of Mental Illness. And then more specifically from the CDC leading causes of death in 2021, we know that suicide is the second leading cause of death in children ages 10 to 14 and the third leading cause of death in children ages 15 to 19. So at the end of the day, this is something that we have to talk about. As uncomfortable as it might be, we can't ignore it. So why can it be so challenging to talk about suicide? I'm going to start by sharing a video that is incredibly personal to me. It is a video that myself and my daughters filmed this spring as part of my team's work on raising resilience. We faced a family tragedy in 2022 related to suicide. And as an expert in this space, I knew it was an opportunity that I could share my story from a lived perspective to further educate and decrease stigma. So please join me in watching this story, and we're going to talk a little bit more about stigma and things that get in the way. Jeff was a goofball, loved sports, loved music, loved his kids, was the life of a party all the time. We met when we were 19 years old, and we grew a relationship for 36 years. And he died by suicide on January 14th, 2022.
I think my dad was a really cool person. He was really funny. Yeah, he was hilarious, and I think sometimes it would annoy us, but I would do anything to hear jokes again from him.
Transit was incredibly important to him, people having access to their lives, and really dreamed someday of running a transit authority, and that dream came true when he became the CEO of MARTA.
He was very personable, and if you ever took the train with him, like, knew the operator's name, always said hi to the person cleaning the station or the person attending the fares.
So when we first learned that Jeff had died, I wanted the right story to be told. By calling it what it is from the get-go, saying suicide, removing that shame that often is associated with that, was an opportunity to educate and to decrease stigma. I am an advanced practice pediatric psychiatric nurse at Children's Healthcare of Atlanta, and suicide prevention has been an area of expertise of mine for more than a decade, which made it even more important and also really hard to talk about. I often get asked, did you know, was there any signs? For Jeff, for sure, there were no signs. This was a complete and utter shock and surprise to our family. He did not struggle with any mental illness. It's an assumption that someone who dies by suicide must have a diagnosable mental illness. And the other thing that I heard a lot was everything seemed perfect. You didn't seem like the kind of family that this would happen to. And I think that really speaks to misconceptions and myths related to suicide. It's a certain kind of person, certain kind of family that this happens to. And at the end of the day, what we know is that suicide doesn't discriminate. This can happen to anyone. We live in a society where expressing your feelings, specifically of men, is still not accepted and seen as a weakness. My guess is that's something that Jeff was struggling with, and that many people struggle with, not being able to express themselves. If we don't change the narrative, we're going to continue to have people who won't seek out help. The way we're going to get at stigma is begin from birth to normalize those conversations around feelings and emotions, which we know build and foster resiliency.
I think we've both shown resilience. Life is hard and complicated and messy, and not everything is going to happen the way you think it is. It's important to learn that at a young age. I think it maybe will allow you to not stuff things in as much.
Part of being resilient is understanding your feelings and emotions, being able to express them, being able to
know what they are, to identify them. I was not able to save Jeff's life. But what I can do is use my voice in the hopes that we can save other people's lives. Suicide can be prevented, and it can be prevented by connection, by talking about it, and most importantly, letting that person know that you're there for them. Hey, I'm worried about you. Something seems not right. I'm here for you. If someone is talking about suicide, no matter what their age is, take it seriously. It is not typical for any person, regardless of their age, to talk about suicide. Get them help. Nationally, we have the suicide hotline number at 988. And it's staffed by licensed clinicians 24/7. There is help, and you can help save a life.
So thank you for allowing me this opportunity to share that video. When we created it, I didn't intend to use it as a teaching tool. I was asked to do it in a community event, and for the first time, despite many times of teaching, I saw an audience shift and pay attention in a way I had never seen before. And I knew that it was an opportunity to use this video as a teaching opportunity. And we're going to talk a lot about some of the things that I mentioned in there a few slides down about the importance of starting early in these conversations and normalizing conversations around feelings. But first, I want to touch on some concepts of what gets in the way of us talking about suicide. Things like negative perceptions related to suicide, that people who are thinking about suicide, people who die by suicide, are selfish or weak. When we portray these kinds of concepts, it prevents people from accessing help and talking out loud about what they might be struggling with. Things like fear. I don't know what to do next if I'm presented with someone with suicide, or I don't know what to say next. I might be embarrassed if I'm struggling with thoughts of suicide, or if I'm a family member who's left behind after suicide. What if I say something that makes it worse? That shame is really a powerful feeling that people struggle with. That shame is what gets in the way of people seeking help. But it also gets in the way of the families who are left behind in receiving help and feeling okay to talk about it. Yeah, this is where I always struggle on this dang thing when there's not a clicker. There are also a lot of common misconceptions out there. And you heard me address some of those in our video, that anyone who tries to kill themselves must be crazy. And what we know is that not everyone who dies by suicide or even have thoughts of suicide has a diagnosable mental illness. We do know that people who have diagnoses such as anxiety or depression are at much higher risk than the general population, but not everyone has a diagnosis. That if they're talking about it, they won't actually do it. So we don't need to take it seriously. We know that we need to take it seriously 100% of the time. If a person is determined to kill themselves, there's nothing that I'm going to be able to do to stop that from happening. And we know that there are lots of things that we can do from a prevention perspective. And people who die by suicide are unwilling to seek help. When in fact, what we know is they don't know how to access the help. They don't know what to do because of all those things I mentioned in the previous slide. And this last concept is something that I've heard many times in pediatrics, specifically when I worked on the psychiatry consult team, and my job was to assess for suicide. And I'd have families say to me, I don't want you asking my kids that because I don't want you to put that thought in their mind. And what we know is no research to support that to be true. Talking about suicide will not cause someone to be suicidal. So how do we talk about suicide? We really need to move to a place where we start moving away from language that is stigmatizing. And that includes saying things like committed suicide, killed themselves, successful suicide, completed suicide, failed attempt, or unsuccessful suicide. Specifically, the word committed, which you often hear, although far less than before, is often associated with crime. So you can see why it's a language that we want to move away from. Instead, we say died by suicide. Suicided, ended their life, took their life, or attempted to end their life. I have no problem correcting someone, and I've never had anyone be offended when I've corrected them, especially if I've done it with kindness and compassion. It's really important for us as healthcare providers to understand what are the risk factors that exist with regards to suicide. The number one risk factor is having a previous suicide attempt. So if you're taking care of a patient and you know that is in their health history, that is a patient you want to pay extra care for with regards to assessing for future risk. When someone has a close family member or friend who has died by suicide, in my world we call that the ripple effect. So those that are immediately around that person. When my husband died by suicide, because I am a helper person and I felt completely out of control, in addition to making sure that the press release called it suicide, I wanted to make sure that the executives at MARTA had the support that they needed. I knew that I could get that for myself and my daughters and my immediate family, but I wasn't so sure that an organization that this wasn't their specialty would have that in place, and they were at high risk. Experiencing abuse, neglect, or bullying, social isolation, lack of support, impulsivity or aggression, easy access to firearms and medications. We're going to spend a lot of time talking about lethal means counseling. But people who are at high risk for suicide, the recommendation is, in fact, firearms to be removed from the home, ideally. And if that can't happen, then they're safely secured. Alcohol or substance use disorders put someone at higher risk. Diagnoses such as depression, anxiety, bipolar disorder put people at higher risk. Within the pediatric population, those same risk factors exist. Sometimes the nuances look slightly different in kids. So we want to pay attention to significant changes in their eating or sleeping habits. When they're becoming withdrawn from their friends and their family and their regular activities, the things that they once really enjoyed, they no longer find joy in. And that doesn't mean the child who's sort of trying to find out where they fit in and they're trying this sport or that sport. They've been passionate about lacrosse their whole life, and all of a sudden they don't want to do it anymore. Those are the kinds of things that you need to be paying attention to. They have a lot of physical complaints, so those somatic complaints, that they'll often arrive in your office. We know that research tells us that those who die by suicide, a very large percent of them had seen a medical provider in the year prior to their death. But likely we had not asked the questions about suicide because it isn't something that we feel very comfortable universally screening for. And the being aware of those warning signs. And the warning signs aren't necessarily warning signs that you have to hospitalize someone over, but that you need to put a safety plan and an approach in place. So anytime someone is talking about suicide or wanting to die, we're going to take it seriously. You heard me say that in the video. I can't say it enough times. It does not matter what age the child is. It is not typical for a child to talk about suicide. We have had children in our state of Georgia as young as 7 die by suicide. A very small number still happens, and we want to take it seriously. Anytime they're talking about death, mood changes that are significant and major, excessive engaging in reckless behavior, and we're not talking about typical teenage reckless behavior, excessive reckless behavior. Giving away things, saying goodbye, those are times in which we really need to be paying attention. But it's also really important to understand what are the protective factors. What are things that we as healthcare providers can do for our patients and encourage those families to do for their children, that wrap them around and help support them. This afternoon, my colleague is going to talk a lot about how do we build resiliency in kids. That's a huge protective factor. So coping and problem-solving skills, which lead to resiliency, are things that we can do proactively that can protect against something like suicide. Cultural and religious beliefs that discourage suicide can actually be a protective factor. You heard me talk about connection. It's very powerful. And when I think of your role as community healthcare providers in small communities, which likely you know everyone in the family and you know lots of people in the community, especially if you work and live in the community, you provide that opportunity for connection. But that could also be their friends, their coach, their religious leaders, their family. Supportive relations, again, with that care provider. I entered every clinical interaction with a child and family, even if I was only going to see them once in the emergency room, with this motto at Children's is today will make a difference in the life of a child. And that I took seriously every single time that I knew I had an opportunity to be a connection to a child in crisis. The availability of physical and mental health care. And we know in rural communities that the mental health care is not always available. And so sometimes you have to be both. And then again, another protective factor is that limited access to lethal means among people at risk. And that includes firearms, suffocation devices, and medications. So I think that it's really important that we as healthcare providers understand that suicide prevention really can start from a primary prevention perspective. And we're going to spend some time talking about that. How do we set the stage that allows for opportunities for kids and caregivers to talk to us about suicide? So let's talk about Mr. Rogers, and I love this quote. People have said, "Don't cry," to other people for years and years, and all that it has ever meant is that I'm too uncomfortable when you show feelings. I'm really curious, and you can call it out, to think about your childhood and your upbringing. What kind of messages were you given growing up about feelings and emotions? This is my third talk of the week, not on suicide, but around feelings and emotions. People always hesitate to say what their feelings and brave, so I usually out myself. So I cried very easily growing up, and I still do, not as much as I did prior to having children, for somehow it changed in childbirth. The ability to cry didn't happen quite as much. But my mother used to call me, "Stop crying, stop being a Sarah Bernhardt," which was an old school actress, even before my time, who could cry on a dime. Now, my mom just didn't feel great and comfortable with my tears and my crying, and probably thought I was being a bit dramatic. Was she a bad mom? No, not at all. She just didn't like it, didn't feel comfortable for her, and that's how she was raised growing up. I'm curious if any of you all were told other kinds of things, to not cry or not to be mad, or boys don't cry. I see some nodding. Yeah. You're not hurt, so don't cry. So crying is only associated with something physical, right? Don't be so sensitive. I'll give you something to cry about. Oh, I definitely heard that too. I'll give you something to cry about. I 100% heard that from my mother. Yeah. Yeah, so we are told these kinds of things very often as we're growing up. And likely some of us have shared some of these things, maybe not to the degree that our parents did to us, but likely we've shared those to our children because we don't feel good about those feelings. I love to share the story of 2 years ago, I had to move my dad into assisted living. And when we were finally leaving, my sister and I, and he was in a dining hall that looked very similar to this. And he began to cry because he knew we were leaving. And my sister started to cry, and I could feel that I was going to lose it as well. And a person came over that worked in the assisted living and ran over to my dad, and a sweet woman, and said, "Oh, please don't cry. You're breaking my heart." And in that moment, I said, "Dad, it's okay to cry. This is scary and overwhelming. And guess what? I'm going to be back tomorrow, and I'm going to see you tomorrow." And then an elderly gentleman sitting at the table spoke up and said, 3 weeks ago, when I moved in here, I cried at the same table, and it's okay. And I'm here for you, and I'm going to support you. And this man was like 84 years old. And it just warmed my heart that he felt safe enough to be able to share his feelings in that moment. And I think that that's something that we really need to get better at and being paid more attention to, the messages we're sending children about feelings. Instead of saying that feelings are good or bad, positive or negative, that we move to a place where we say that all feelings are okay and normal. And we're creating spaces as healthcare providers that says that our kids can talk to us about anything. So the American Academy of Pediatrics and the American Foundation of Suicide Prevention collaborated with experts from the NIMH to create this blueprint for youth suicide prevention educational resource for pediatric health clinicians. So when I was preparing for this initial lecture that I did for the Department of Behavioral Health and Developmental Disabilities this summer, I came across this blueprint. And I actually think they did a really great job creating some guidelines for pediatricians to sort of think about how do you create this welcoming environment that allows for opportunities for patients to feel safe about talking about anything. And that starts with talking to your clinicians and your staff and yourself and reflecting on what your biases are in general, but specifically around mental health diagnoses and disorders. Using inclusive and reflective language and imagery. Think about your practices. Are they reflective of the community you're serving? Does it feel welcoming to them? Being specific about asking your patients their names and their pronouns and then using those consistently. And utilizing what we call those trauma-informed approaches and principles that support and promote relational health. I couldn't say more about the importance of relational health, which really speaks to that idea of connection. And I'm going to make an assumption here, but I think I'm probably on target, that you all in small communities got this going well. I'll bet you all do this super well, and that those of us in the urban space could probably take note and model more of what you all do with regard to relational health, because you're often it for them. We also have opportunities to support emotional expression. Rachel's going to talk about this more in the afternoon, but I'm going to touch on it. And that really starting as early as the time the child becomes verbal, or modeling what that looks like for the pre-verbal children, about how to identify and label our feelings. These aren't things we aren't born knowing how to do. We have to be taught. We're pretty good at helping babies figure that out because they don't have verbal skills, and we talk for them and we say, I wonder if you're sad, I wonder if you're hungry. But as kids grow and develop and get verbal skills, we don't do that as well. So they don't learn the layers of feelings. And so we want to encourage families to look for opportunities to routinely and openly talk about feelings. And that might look like at the family mealtime or on the way to and from school. How was your day? What was the best part of your day? What was the hardest part of your day? Simple things like that help open up doors to allow communication to occur. I wonder statements, I talked about it using with babies, but we can use them with older kids as well. I'm wondering if you're feeling frustrated. Is that right? It's not me telling the child how they feel. It's me getting curious and asking for clarity. We can also promote emotional expression through these communication strategies that we all learned at some point in our careers, probably. Open-ended questions, active listening, reflective listening. When I was on the psychiatry team and I would come out after I'd done an assessment, I'd gather all the information, and the attending or the nurse would ask me, what did I learn? And I would share what I learned, and they were like, how did you get all that? This is how I got all that. These are the strategies that I used. I sat down, I leaned in, I nodded along, I exuded a sense of presence for them. I said, what was the hardest part of your day? Child responded, I didn't have anyone to sit with at lunch, and it was so embarrassing. I reflected back. It sounds like lunchtime didn't go as well as you hoped. Is that right? We also can promote emotional expression by normalizing, validating, and allowing all feelings. I can understand you might feel that way. I've had that happen to me before too. It's normal to feel embarrassed. I couldn't tell you how many times when I've said that I had a similar experience to a child and they think, really, you did? Because they can't imagine anyone else ever experiencing what they're experiencing. And it is so rewarding and helps with that connection. So as we wrap up thinking of this prevention approach, we can encourage emotional expression. We can proactively teach coping skills. I really truly encourage all of you, if this isn't a part of your clinical practice already, to think about where in your visits, whether that be a well child visit or a follow-up visit, can you reinforce the proactive practice of coping skills? Meaning you're encouraging kids and caregivers to look for opportunities to weave coping skills of any kind. And that might be listening to music, going for a walk, writing in a journal, to more structured ones like deep breathing or guided imagery on a daily practice. And the way we set it up is this is how we manage what life throws at us, whatever that might be. We're going to educate on mental health. I've heard the word mental health talked about a lot. And interestingly, I think even in healthcare, when we talk about mental health, we talk about it as if we're talking about mental illness. Mental health is like physical health. Mental illness is a part of that. Mental health is what we do to stay healthy from a mental perspective. So helping families understand that. But then specifically educating on the connection between our physical health and our mental health. And an amazing way we can do that is through our healthy habits. Strong for Life, that's what we're all about, our healthy habits. So when we're educating our families on the importance of nutrition, we make that direct connection of how it helps us be physically strong and mentally strong. And being very intentional in that. And as healthcare providers, we have a great opportunity to do that. We also can educate kids and caregivers about suicide. And what's really important is that we avoid language that creates this sense of crisis with regards to suicide. And while we definitely know that suicide rates have been rising, when we use the word crisis, it often puts so much fear in someone that they don't hear the rest of the things. But instead, we offer hopeful messages that they're not alone and that help is available. If we're going to be screening in our practices for suicide, that we explain why we're doing this. And I have some examples of some scripting that you all could use in your practice if you choose to screen for suicide. And then we make it clear that we take it seriously, and this is important to us, and we use compassionate language. It's really important that we educate both kids, specifically older kids, and caregivers on the risk factors, the warning signs, and the protective factors of suicide. And of course, in pediatrics, we know this, that we always want to use age and developmentally appropriate language. This next one's kind of tricky because it's a little scary to talk about something. And you heard Dr. Mann mention this isn't something you all are trained in medical school, really understanding and knowing about mental health. As an undergrad nurse, I wasn't either at all. I had 1 6-week session of behavioral mental health, and that is it. So it isn't something we know a lot about. And when we don't know stuff, we end up sometimes inserting our own fear or judgments when we talk about suicide. And it typically comes from a place of we don't feel comfortable, we don't have all the answers. It's really important that we address confidentiality. So the way I always address that is what you say to me is so important, and I can keep it confidential with the exception of things to do with your safety or the safety of someone else's. And I start that out anytime I interact with a child, regardless of what the assessment context is. We're going to start early, we're going to ask often, and we're going to be direct. So I'm going to spend this next bit of time talking about some of the evidence-based screening tools that exist for pediatrics. And I'm going to apologize in advance because I cannot stand busy slides, and these next few slides are quite busy. But they're busy, purposeful, not for us to read them all, but just to let you know that this exists for you to look at. So the NIMH has on their website a care pathway. And if you're someone that really sort of likes some structure to that, I wanted to at least visibly show it up there for you. And I think that it's particularly helpful for people when they're starting from a place of unknown. And they really need to know, it's okay, this is what I do here. If it's positive, this is where I go next. If it's negative, this is where I go next. And this does a beautiful job outlining that. So basically the child comes in, you're using your screening tool, the child screens positive, then you sort of move to the risk assessment of what level of risk, and we're going to talk some more about that. And then it moves through the flow chart. So the American Academy of Pediatric recommends suicide screenings in the following ways. I'm going to put a caveat to this. I appreciate that this is the recommendation from American Academy of Pediatrics. But those of you specifically in rural areas may not have access to a lot of behavioral mental health services to support a positive screen. So you may not choose to screen universally. But I do highly encourage you to at least screen kids that are in the high-risk populations. Because I can tell you right now, they're likely having thoughts of suicide. And it is much better that you know that because you have an opportunity to intervene sooner. So I'm just going to say what the recommendations are, but I also appreciate that you may have limitations. So the recommendations is that we universally screen all children 12 and older. And when we think about universal screen, the plug I want to give is when we do universally screen, we're creating a sense of that this is just something normally we do in our practice. This isn't something that we're just sort of hiding behind and we're whispering about, right? And that with kids from ages 8 to 11, that we're going to screen only when it's clinically indicated. And then kids under the age of 8, we're not going to screen because the tools are not evidence-based for this age category. But of course, we're going to evaluate and assess, likely with a mental health professional, if children are expressing thoughts of suicide or are having warning signs that are of concern. So the ASQ is one example of an evidence-based screening tool that I'm going to talk about in a few slides. But as part of, on the NIMH, where we have that care pathway, there's also a toolkit that includes the screening tool, but a lot of scripting on how you can talk about the screening tool in your pediatric primary care setting. They also have one for the emergency room scripting. They have one for the hospital setting. They've done a really great job sort of working that through. Dr. Lisa Horowitz is the primary researcher behind this tool, and I have had direct conversations with her for years because this screening tool we use at Children's, and before we brought it to Children's, she was very readily available. So I do say that if you go on this website, you'll see her contact information. If you email her, she actually gets people, she emails you back. That's how passionate she is about this. So this screening starts from a place of what do you say to the parent and guardian about why you're screening? Once the parent steps out, what you say to the patient. If the child screens positive, then what do you say? And it really gives you language. And you literally could read from it until it becomes your own, if that's what you feel comfortable doing. The next is the actual ASQ screening tool. And I think that what is important to know about the screening tool is that it is a 5-question screening tool that helps you distinguish whether it's an acute risk or a non-acute risk. So the first 4 questions, if they are negative, you don't go any further, meaning the child says no. If they say yes to any of them, you ask the 5th question, which assesses the acuity level, right? So if the 5th question is, are you having thoughts of killing yourself right now? If the answer is no, then it's a non-acute risk, meaning you likely have to put together a safety plan and things like that. If the answer is yes, it's an acute risk. And that's where you will escalate it up and refer out likely in your clinical practice. Or at least if you are lucky enough to work with a co-located mental health professional, you can have that person do a further assessment. The next evidence-based screening tool, it's the ASQ, but some of you may be using the PHQ-9A, which is for adolescents, the depression screen in your practice, and that's just your standard practice. And you don't want to universally screen, but the question 9 is a specific question related to suicide. And if the child screens positive, they have combined these tools together so you can go right into assessing using the ASQ. I do want to say that it's really important to understand that the PHQ-9 is a depression screening. It is not a suicide screen. And that is really important to know. So if you thought that you were using this tool to screen for both depression and suicide risk, it's not, there isn't evidence to support. There's lots of evidence to support that actually we've missed a lot of children who are actually having thoughts of suicide that don't screen positive on this tool. So I do encourage you that if you're going to use the PHQ-9 and not screen universally for suicide, that you join this with the ASQ or this next tool that I'm going to talk about if the child screens positive on question 9. And the last tool that I'm going to talk just really to show you is the Columbia Suicide Severity Rating Scale. And like the ASQ, it helps you determine acuity, whether it's an acute risk or a non-acute risk. And then you're able to determine next steps based on that. So the next we're going to talk about this idea of a brief suicide safety assessment, or a BSSA. And this is, again, I appreciate you all may not be very comfortable with the idea of even going down a path beyond a positive screen and then sending the child to a mental health professional or an emergency room for a further evaluation. If that is what you choose to do, then that is what you choose to do. But what we do know is that when we send a child to the emergency room every time they have a positive screen, it can result in the kids not being truthful on a screening the next time. So that is really important, because not every child that screens positive needs to be hospitalized. And so becoming more familiarized with this BSSA, I highly encourage you to do. Read it. That toolkit that I mentioned on NIMH walks through with scripting on how to utilize the BSSA. So what the BSSA is, it's not a screening tool. It just helps you identify risk to be able to understand what are the next steps that I have to do. This is a super busy set of slides, but I really wanted to visually show you what a BSSA looks like. And basically what it does is it's a tool that walks you step by step, written out, you can read it, to help you understand risk. The first is around suicidal thoughts. And so it asks about, in the past week, have you had thoughts of suicide, and how often? And are you having the thoughts now? If the child is having thoughts now, and the answer is yes, you don't go any further on the BSSA. That is an urgent risk. That child needs further assessment at a mental health facility, at a receiving hospital, an emergency room, call 988, whatever it is, the resource or policy in your office, but that child needs immediate further evaluation. If they're not, the answer is no, meaning I'm not having thoughts right now, then you'll move on through the BSSA. And you're going to ask specific questions related to suicide plan. And this is really important, because the child may say, yes, I've had thoughts of suicide in the last, 3 days ago. do you have a suicide plan? No, I don't have a plan. I would never act on that. Then it's really important to say, well, if you were to, what have you ever thought about what you might do? And if the child is really detailed in their plan, that is a high acuity risk, and I would send them for further evaluation. But if they've never had a plan, they've never really thought about it, they just have these passing thoughts, they're not a high acuity risk. And that's likely a child that you can send for further evaluation for a therapist, not an emergency room. You want to assess for past behaviors, meaning, remember, we talked about the number one risk factor is a past suicide attempt. So knowing that escalates the risk for that child. Now, that doesn't mean that that child who maybe had a suicide attempt a month ago, 6 months ago, 3 years ago is at extreme risk. It just means something that I have to keep in my head as I go down on the BSSA. We're going to assess for symptoms. And so those symptoms might be things like depression or anxiety. So anyone that has a diagnosable mental illness is at a higher risk. So understanding that. This social support and stressors includes sort of both the stressors and the protective factors. So knowing what's in place for that. Are they having bullying? But who is their support network? Do they have a lot of people in there? Yes, I'm being bullied, but I feel very connected to my school counselor, and I have a lot of support with my other friends. It's really important that we interview the patient and the parent together. And when we're doing this component of it, we're trying to get a sense of what is the child's understanding of what's going on and what is the parent's understanding of what's going on. And then it's also important to ask the parent, is there anything that you'd like to tell me outside of the room? Because I definitely have worked with parents that don't feel comfortable talking about certain things in front of the kids because they're worried about how the child will take it, perceive them, that kind of thing. And then we're going to make a safety plan with the patient. And we're going to make a safety plan with children who are at moderate risk. But honestly, even the child who's at higher risk, because they're going to be sitting in your office for a bit of time before they're going to go out somewhere. So this is a really great opportunity to come up with a conversation with the child and the family to think about what can we do? What are the things that we can put in place that help you feel safer? And we're going to talk a little bit down about what a safety plan actually looks like. And then at this point, you're going to determine the disposition. And that'll depend on some of the data that you gather on whether this child is a low risk, a moderate risk, or no risk at all. And that really is based on all of the things that you gathered. So we're going to wrap this presentation up in this last section on breaking out how do we care for kids who are in these various categories, the imminent risk, the moderate risk, and the low risk. Specifically, how do we talk to the child and how do we talk to the caregiver? What kind of tools, what might we use, like the safety planning and lethal means counseling? So that first group of kids are the kids that are at imminent risk for suicide. And what you're going to notice in each of these categories is a lot of similarity and a lot of what we talked about from this prevention approach. So we're going to start with listening without judgment. We're going to use that active listening. We're going to say things like, thank you for sharing your thoughts with me. It can be hard and scary to share your thoughts of suicide. And I want you to know that I think you're very brave and I'm here to help you and you're not alone. That is a really powerful statement. Now, I don't say exactly like that, right? I make it my language, but I always have said to a child who has been brave enough to share their story with me, specifically around suicide, thank you for sharing that story with me. I know how hard that was for you to talk about. We're going to explain that confidentiality scenario. We're going to let them know what to expect. And this is really important. It's really scary for the child to be able to tell you this and then sit not knowing what the next steps are. And the last thing is super important. We want to empower, these are more the older kids, certainly the middle and high school kids, and giving them some voice and choice and how they want their caregiver to be told. Their caregiver has to be told. But we can ask them, would you like to tell your family? Would you like me to tell your family? Would you like me to sit with you while you tell your family? Would you like to sit with me while I tell your family? I've had kids answer in a variety of ways. I've had kids saying, I can't tell them, and I don't want to sit next to you while you tell them. And so I arrange for a safety person to be with the child while I tell the caregiver. And then with regards to the caregivers of youth that are at imminent risk, it's really important that we think about our words. remember those hopeful messages. That we avoid language that places blame and makes them feel guilty. So unintentionally saying something like, "Did you know anything about this?" And that's our attempt to try to gather information, but it can often come across as accusatory. We could instead say, "I can imagine how hard it is to hear this. I'm wondering if you have had any concerns, anything that you noticed over time." Again, that active listening. Sometimes when we get anxious, we tend to talk more, listen less. Listening is incredibly important. Informing them of next steps in the plan. Connecting them to care. And while it may seem like, do I really need to talk about lethal means counseling when I'm sending them to an emergency room? Aren't they going to talk about it? Well, I hope they're going to talk about it. But it doesn't hurt to talk about it as many times as possible. And lethal means counseling means asking the question, are there firearms in the home? If the answer is yes, the recommendation when someone is at high risk that firearms are removed from the home. And if that is not an option for that family, then having a clear conversation around what safe gun storage is and looks like. And in a couple of slides, I have a QR code that navigates to an article that our CHIP doctors wrote on exactly that. But it also means safely securing medication, both over the counter and prescription medications, and having a conversation regarding things that can be used as suffocation and monitoring that. So things like belts, shoelaces. The next group of kids are the kids that are high risk, but they need further mental health evaluation. And ideally, that would be the child that you would either help set up with a mental health professional within 72 hours of the assessment, and that you yourself also probably do a follow-up call with them. So again, that same things that we did with the child at high risk, we're going to do here. We're going to thank them for sharing. We're going to talk about the confidentiality. We're going to listen without judgment. We're going to let them know what to expect. You were really brave to talk to me about this. And I'm going to work really hard to get you connected to a mental health professional so you have someone to talk to. And then you're going to ask them, how would you like your family to know about this? Would you like to tell them? Would you like me? And then those same things with those families, the same things we did in that first scenario, we're going to do here. This is when we want to sort of begin to talk about the idea of a safety plan. And I'm going to go over that in the next slide. If you want to navigate to our article on safe gun storage, that QR code navigates there. You're going to give them information on 988. Hopefully that wasn't a new number that you heard in the video, that everyone is aware of 988. It rolled out in July of 2022. It is a 911 equivalent of mental health crisis. It is staffed by mental health clinicians who are trained in crisis work, and it is 24/7. It navigates in our state through the Georgia Crisis and Access Line, which I'm pretty proud of. There are many things in Georgia from a mental health perspective that we're behind in. This was not one of them. So when 988 rolled out in July of 2022, we actually were better equipped than other states because we had a system in place already. Additionally, on our website, and Rachel's going to go over all of our different resources later this afternoon, but we've also created this teaching tool that I'm really proud of, behavioral mental health services, that educates families on who are the various kinds of clinicians that provide mental health care. A lot of families are aware of what a psychiatrist is and a psychologist, although I will say they often flip who does what in those 2 degrees, but they don't know my credential, and they don't know an LCSW, and they don't know a licensed professional counselor or LPC. And those 2 disciplines often provide in LMFTs the largest workforce of mental health support. So helping families understand that, and that's laid out in the first half, as well as all the evidence-based treatment that we use in pediatric mental health. And the back of the page is, if I'm looking for a therapist for my child, what kind of questions should I be asking as I'm looking? And then once my child's in therapy, what should I expect? The next is a safety plan. So safety plan is not a safety contract. It is not a legal document. It is simply a way that is organized and involves the patient and the family to think about the child's crisis signs, some coping strategies, supports that are in place. And this is an example of the safety plan that we use in Children's Healthcare for Atlanta. It is available if you honestly, truly Google safety plan. This one actually comes up, and you just have to get permission. I'm on the State Suicide Prevention Task Force, and in our meeting on Wednesday, they announced this safetyplan.org, which I highly recommend. I navigated to it last night, actually, for the first time. And you can actually download an app which allows, and so the patients can put that on the phone to digitally do one in real time, or you can print out a handwritten one as well. And so all classic safety plans are categorized in this way. And so the first part of a safety plan is always about having the patient identify what are the warning signs that tell me that a crisis is brewing. And sometimes this is tricky for a kid to figure out. And so you might have to use language that makes sense to them. So it might be like, when do you notice that you're really, you're really going to have an outburst, and really get specific about that. And that's usually how I can get kids to sort of think about what their body feels like, sort of what are the things that are happening around them. And then the next is, what are coping skills that only you can employ? Meaning you don't need anyone's help to do that. What are the things you have internally that help you feel better? And then who are the people or social settings that provide distractions? So these aren't therapeutic people per se, meaning they're not professionals. And so it may be that when I take the dog for the walk is something that provides me a distraction, or my grandmother's house is another place that I enjoy going to. And then who are the people in your life that you can ask for help? And I will say, when I'm working with teenagers, they will always want to put all kids on there. And that's completely developmentally appropriate. But I encourage them to put at least 2 adults and then 1 youth on there. And then the last, or step 5 of there, is the professionals. And so some kids may not actually have a professional in their lives, but if I've connected them to somebody, that's where I'll write the person's name for the first time, unless they already have a therapist. And then ensuring that they have the 988 number there, and the local urgent care services or the community service board in your area would be a great resource to put on there. And then the next step 6, is making the environment safe. So that's where that lethal means counseling can come in. And it's a great time to have direct conversations about asking about firearms in the home. And then the last one is that really important thing around hopeful messaging and protective factor, which is, what is the one thing that is the most important and worth living for? This is a really powerful statement. And I couldn't tell you how many times a child has struggled with that, but when they finally are able to say that, the relief that leaves sort of the parents, that they have something that they can hold on to, is important. And then the person doing the safety plan signs it, the patient signs it, and the parent signs it. You keep a copy for the original copy for your medical record, and I always make a copy for both the child and the caregiver. And then the last group of kids are the ones that are at low risk. And this is those kids that have that history of suicide in the past, or maybe they've screened positive on the PHQ-9 adolescent because that's what you're using in your practice. Or if you're screening for anxiety, they screen positive for anxiety. So this is a time where we really want to be intentional about educating about protective factors, ensuring those coping skills, those problem-solving skills. That we're talking early and often about suicide, and we're not avoiding using that word, and that we're validating all of their feelings. And same for the families. This is a time that we really want to educate them. Sometimes when families have a child that has had a previous suicide attempt or thoughts of suicide, and they're past it, they don't want to think about it again, because it was so hard for them to live through that they think we're done with it. And it's really important for them to know that their child's at higher risk than the general population, so they just have to have it on their radar. That does not mean that they're walking on eggshells for the rest of their lives. It just means it's not something they can forget about. We're going to give them mental health referral options if that's indicated. We're going to talk often. And again, we're going to have opportunities around lethal means counseling and being really intentional about that. So as we wrap up, I think it really is important to equip ourselves with, how do we talk to youth after a suicide has happened? And this can be really scary because we don't feel comfortable as humans about that. And I can say that when I came back to work at Children's Healthcare of Atlanta after my husband passed away, I watched people struggle with what to say to me. And they would hover at my desk, and I would have people saying, I don't know what to say to you. And my response was always, well, if my husband died of a heart attack, what would you say? And they were like, I'm so sorry for your loss. It's the same thing, right? It's not any different. And we need to equip families with the language to be able to talk about that and to talk openly with their kids. So when we think about the littles, or any of these kids for that matter, we're going to ask them what they know from an age and developmentally appropriate approach. But we're always going to let them lead the conversation. And when they're real little, we're going to keep it simple. Okay? Short answers. The person had a disease in their brain and it took over, might be an example of what we might say. When they're in elementary school, we might give them a little bit more information. But again, we're going to be really mindful of the details, but we're not going to avoid talking about that the person died. By the time they're in middle school and high school, however, they have heard this at school. And they may very well have known someone who has either attempted suicide or maybe even died by suicide. So again, asking them what they know about suicide. I know this is something that's in the news a lot and that kids are talking about. Tell me what you know about suicide. And following their lead. Specifically for the middle school kids, this is a great opportunity for you to dispel any misconceptions that they have around suicide, because they likely have a lot. By the time they're in high school, they may be struggling themselves with suicide. So this is an opportunity for you to ask the direct question, have you ever had thoughts of suicide? I also want you to know that it's normal for people to struggle with things like depression or anxiety. So if you have those kinds of thoughts or feelings or worries, I want you to know that coming to me and talking to me about it is okay, and that there's help available and these can be treated. These are incredibly important things. When my daughters and I created this video and it was released in September for Suicide Prevention Month, and it was released within Children's and it was released on social media and everywhere, I was flooded with countless emails and texts from people that I knew, but one in particular stood out to me. It was of a nurse that I didn't really know that well, who based on the video went back and had an intentional conversation with her husband. Have you ever had thoughts of suicide? That was not something that they ever talked about. And she learned that her husband had fleeting thoughts. And just by having that conversation, they created an opportunity for that to feel okay to talk about. And they made a commitment to regularly check in about their feelings and make it normalized and then model what that looks like for their kids. So we all have an opportunity by having these frank conversations and not being scared to talk about it. We don't have to have all the answers. We can admit, thank you for sharing that with me. I don't know exactly all of the supports, but I know who to ask for. I know who to ask for help, and I'll gather more information. I've listed a bunch of resources for you all, and I will make sure that Kedrick sends these PowerPoints to you in a PDF form so you'll have the resources. And then Rachel's going to go over all of these resources that are attached to our Building Resilience training, but these are also available on our website. So if you want to encourage families to navigate them, really what these do, these coping skills and feelings posters, by printing them out and putting them on refrigerators, is you're creating opportunities that normalizes that we all have feelings and that we all should be proactively practicing coping skills. We have these community resilience tip sheets, and we have coping skills tip sheets. And then I'm really proud of our Raising Resilience campaign that launched in 2021 that our story, our video is a part of. And I encourage you to encourage your families to navigate to these resources. They can sign up for our Raising Resilience email series. And no matter when they sign up, they'll get the emails from the beginning and then get them in a sequential order. And if they go to our website, raisingresilience.com, it is crafted in a way that if I'm a parent of an infant and I only really can handle reading articles on how do I build and foster resilience in my infant, I can just click on that one section and navigate all the content that we have on there. You can follow us on social media. And then I do encourage you to check out our other videos. I'm really proud of all of the videos we've created. They're real families and real people who have various kinds of ups and downs that they've faced and are willing to share their story of various kinds of lived experiences. So I'm really tight on the time, but I will allow for any questions that any of you all might have.
Thank you so much for sharing your story. This may be a long-ended question, but when I have patients, whether a child or an adult, who says they want to die and they may have a suicide plan, I always struggle with how to approach going to a hospital. Of course, I've done that, but a lot of times, your patient will, not want to do that. Oh, I'm not really at risk. I'm not really planning to do that. I don't want to go to a hospital. I just want to start medicine. I want to see a counselor, and it's kind of hard to employ making them go or really suggesting that. Any way to navigate, any tools that you would recommend?
So I think that's when I can speak more for pediatrics than I can speak for adults, because adults are not my area of expertise from a tool perspective. I think that is where when we use evidence-based screening tools. So if a child is sort of articulating that they're having thoughts for suicide, and say that it isn't something you universally screen for, but they make that statement, then I would use the ASQ as a way for me to help understand, is this an acute risk or is this a non-acute risk? Because it's a standardized approach. And if it's an acute risk, meaning they say, I'm having thoughts of suicide now, then I would then move into the BSSA form, which then helps me understand, is this really a child that I have to send to the emergency room? Or is this a child that I can put a safety plan in place, that I can connect to a therapist within 72 hours? And I appreciate that in this area that may not always be possible, but with telehealth, I feel like we've gotten better at having a little bit better access, but they could at least come back and see you within 72 hours. And so I think that if you use this sort of standardized approach, I will guarantee you there will be a much smaller percentage of kids that you actually have to send to the emergency room. But in the pediatric population, if you assess that a child is at a very high risk, then you are obligated to have them go to the emergency room and have further assessment. And so that it absolutely gets tricky. I couldn't tell you how many times in the emergency room where we determined that child's a high risk and then needed to be psychiatrically admitted. And you get into this struggle with families. But usually, I will say that I can probably only remember in my 16 years at Children's and my 35 years in being in this space, a very small percentage of like 3 families that really continue to push back. And a lot of times when families are pushing back, it is because they are petrified. And it's based on the stories that they've been told and spun about what happens when a child is hospitalized. And so when I can alleviate their anxieties around that and we can partner together, I usually can get families to agree for further assessment and evaluation. But I think a standardized evidence-based approach is the best way to go.
Yeah, thank you so much for the presentation and your story. The screen you mentioned is good for children. If you're in an integrated practice where you're seeing adults and kids, how far should you use the different screening tools? Up to what age? 20, 25? So when you have those integrated practices, or you're a pediatrician who's seeing kids up until they're 25, is this tool still work for that population? So where's the cutoff? And then what might you recommend in a transitional phase?
So the ASQ is evidence-based up to mid-20s, and the Columbia has an adult version of that as well. So I can't specifically speak to like what age range, but there are adult versions of both of that. And then the ASQ, while it first started in just pediatrics, it has expanded over time. So you're safe to use the ASQ with an older population as well.
Great. And what's the recommendations to screen up till?
Oh, everyone.
Everybody?
Everyone.
So over, so teenager and then above through adulthood.
Correct. The recommendation is truly to be, ideally, to universally be screening everyone. And when we universally screen, what we're doing is we're chipping away at stigma. We're saying that we take this seriously, and so we're screening everyone, just like we screen for all other kinds of health adversities, right? When we do that. But we don't feel super comfortable with the screening everyone, and we don't have enough mental health professionals in there, and so that gets in the way, and that creates a barrier.
I'm just trying to reflect if I've ever been screened before when I go to my primary care provider. I don't think I have.
I have never been. Yeah. And I will say that, my children are older. They're 29 and 23, so they didn't even get the PHQ-9, which is a lot of practices are using now. And they got more of those standard questions, which you knew, like Bright Futures was getting into a place of having pediatricians ask questions around depression. And so my younger daughter, who is now 23, she was 12, her pediatrician, the way in which she framed it, and our pediatrician was wonderful, but you could tell she just didn't feel comfortable with this stuff. And so she said to my daughter, you don't ever feel sad, do you? That was her way of screening for depression. And when we got in the car, Izzy said, well, she clearly didn't want to know that I was feeling sad. And this is my youngest, who's not in the mental health field and not the most touchy-feely. And she picked up on the uneasiness in the pediatrician's practice. But that really came from a place of, we haven't done a good enough job helping support people to feel comfortable around behavioral mental health topics. And when we don't feel comfortable, we're going to say things like that. And that's just, we have to get better at supporting pediatricians and providing them education around behavioral mental health topics.
Thank you.
Mm-hmm. Any other questions? I know I'm keeping you all at lunch, so that's an important thing. So thank you, everybody.
All right, ladies and gentlemen, we are ready to reconvene for our final speaker for today's conference. So our final speaker is Rachel Whaley. Rachel is a social worker, youth development leader, and health equity advocate at Children's Healthcare of Atlanta. As a part of the Strong for Life team, she implements emotional wellness programming in clinical settings and mentors children living with chronic autoimmune disorders. Rachel earned her bachelor's degree in social work from the University of Wisconsin-Madison and went on to earn her Master of Social Work degree from the University of Wisconsin-Milwaukee. Ladies and gentlemen, Ms. Rachel Whaley.
Hello, everyone. If you don't mind, we're going to start out by just scanning this QR code. If you are getting continuing education credits, this is to ensure that we have your information and that you get all of those. If it's not coming up for you for some reason, I'll have this about halfway through the presentation as well. And I can always go back at the beginning, but I'll give you about 20 more seconds here. It should just be a web page with a couple of questions. And while you're doing that, I would love to give you our official welcome to Building Resilience, a Whole Child Approach. All right, I promise you will see this exact QR code again, but I am going to move on forward. I have no disclosures to share with all of you today. And just as Kedrick said, my name is Rachel Whaley. I have about 10 years of experience in social work and youth development. And I also have about 10 years of experience as a young person with my own chronic autoimmune condition as well. So both being a patient and having a passion for working with youth is really what fuels my why behind the work that we do and the incredible work that you all are doing. So I believe you saw my colleague Erin speaking before lunch, but I come from the same group that she does, Children's Healthcare of Atlanta, and within that, Strong for Life. So our goal is to really start with that whole child approach, and we do that by working with the whole community. So I have the honor of working with providers to deliver our resilience information, and then the other members of my team work with adults in schools, in early childhood education centers, in summer camps, in faith-based organizations. So we are all around the community with the goal of sharing some aligned messaging when it comes to prevention education and supporting our young ones. So our objectives for today are to increase knowledge of your role in building resilience in all youth. So these are strategies from a prevention and promotion kind of lens. So these are strategies that we think can be applied to all of our young people and all of our patients. We also want to increase your knowledge of the strategies to build awareness, identification, expression, and proactive management of feelings in all youth. And we want you to feel comfortable utilizing the toolkit items to build resilience during those well-child visits. So I am going to share out some statistics to start us. I think it can be really helpful in just kind of grounding what we do and why we do it. But likely these statistics are not going to be huge surprises to you. You all are the ones on the ground doing the work day in and day out. So you are probably well aware of these statistics. They might even seem higher in your area. So we know that 1 in 6 children in the U.S. from birth to age 17 has a mental, behavioral, or developmental disorder, and this comes from NAMI, the National Alliance on Mental Illness. We also know when we will look at our leading causes of death over here on the left side, when we're looking at youth aged 10 to 14, we have suicide here coming in at second. And when we look over on the right side of this chart, youth aged 15 to 19, we see suicide being the third leading cause of death, only to recently be replaced by homicide. We want to talk about this for a couple of reasons. One, we know that when depression and anxiety are present in our patients, the risk for suicidality goes up. So that's something we always want to be aware of and screening for. And on this right side, we see unintentional injury, homicide, and suicide. Those are all instances where firearms can be involved. So if you're like me and if you're still learning to have some of those challenging conversations when it comes to asking about, are there firearms in the home where my young person's going to be? Or having conversations with families about safe storage in your well visits. This is a QR code that links to an article that our injury and illness prevention team put out there that just has some really helpful talking points to be able to take it and make it authentic to yourself if that's a conversation around safe storage that you would want some support with. Also, when we talk about mental health and when we're talking about firearms and safe storage, I always like to point out that our evidence does show that when we think about firearms and mental health, folks who are living with mental health conditions and mental health disorders are more likely to harm themselves than others. So when we talk about mental health and trying to disband some of that stigma, which we'll get to more of, that is something that we want to be mindful of as well. So we also know that about 50% of all lifetime mental health cases begin by the age of 14. So that is half of those symptoms are popping up before age 14. And I want to know what you think the number of years on average is between the onset of those symptoms and intervention. So between the time that we're seeing symptoms and direct support is being given, how many years? Feel free to throw it out there. 5, okay. 10. Anybody 20, 30, 50? No, 5 to 10, okay. We're right around that range. So 8 to 11 years on average. And of course, this is national data. So it might be a little bit different depending on where we are and who we're talking with. But I share the statistic all the time, multiple times a week, and it still is really jarring to me every time that I read it out loud. 8 to 10 years we know is such an incredibly long time. So why do we think this large gap exists? Why is it a decade between when we see those onset of symptoms and when we see some support? Stigma, yeah, absolutely. What else?
Denial.
Say it again. Denial, absolutely. And when we talk about our young people, when we talk about caregivers, they might be in denial because that can be really hard to accept. They might also not have education around that. A lot of our young people may not know that the physical symptoms that they're experiencing can also be linked with their mental health. So if I'm a middle schooler and I'm getting terrible stomach aches around the same time once a week, it might be a GI issue, right? It might just be solely physical. once we start asking more questions and opening up the conversation, we might start to see, oh, maybe it's related to anxiety. Maybe you're having really big tests those hours that you're getting these stomach aches right before. So if I'm asking the open-ended question, talk to me about what's going on when you get those stomach aches, right? When we open it up for more conversation, we're likely to be able to speak to that mind-body connection. So this is a quote by Desmond Tutu, South African human rights activist and Nobel Peace Prize winner, that we think really speaks to the work we do and why we do it. So as I read it out loud, I just want you to be able to think about how this relates to mental health. There comes a point where we need to just stop pulling people out of the river. We need to go upstream and find out why they're falling in. So that is really why we do the work that we do. And when it comes to mental health, we know that we're in the midst of a mental health crisis. And so we want to be able to think not just about intervention and what are our young people's needs right now, but how do we start to plan decades before that and try and have conversations with them, support them with those skills that they need for the ups and downs of life. So that is where we start talking about building resilience, which is the core of what we're going to continue talking about today. So when I say resilience, I'd love to hear from 2 or 3 people. What are some words or phrases that come to mind? Hanging in there, yeah. What else? Yeah. Unbreakable, yeah. Bounce back, yeah. We get that one a lot. I see some nodding heads for all of those too. Anything else? Yeah, so when we think about resilience, we have multiple different definitions. And I know for me, when I was a young person, bouncing back was the most common kind of term, or powering through, right? Put your head down, you got this. To be resilient, you're strong, you're unbreakable, right? And there's a lot of power and strength in those messages, so we don't want to diminish those. But we also want to recognize that if we're focused on bouncing back to the same place we were in before a challenge or adversity, we're likely not learning anything from it. And we know that adversities change us, right? So we want to be able to equip our young people to move through those adversities, to be able to learn from them and feel prepared to handle life's ups and downs. So that's really just the simple definition that we use as a team, the ability to handle life's ups and downs. So we know that resilient children are better able to cope with challenges, manage stress, and make healthy choices. And we know that we're all capable of building resilience, not just young people, but ourselves. I am continuously building my own resilience. It was a long car ride for me to get here. There was a lot of traffic and I was running up those stairs. So as you can maybe see under the beautiful bright lights, I'm glistening in sweat still. So it's not just young people. We can continue to build our resilience as well. But really the reason that we want to continue to do that is because we're all so comfortable talking about physical health, right? But it is just as important when we're talking about growth and development that we align that with mental health too, because it all falls under the category of health. So when we're speaking to mental and physical health, that's really when we're going to start to be able to foster that resiliency. These are our healthy habits. These are things that I am sure are a part of your everyday conversation with youth and families. Eat smarter, drink water, screens away, go play. Get rest to be your best. That's my favorite one. Anyone else in the crowd like rest? Yeah, okay, thank you for nodding your head. And then emotions are real, express how you feel. So that's really where we step into incorporating more mental health strategies. And from a prevention lens, what that really looks like is identification, expression, and management, coping with feelings. So on a scale of 1 to 5, or since I'm going to say you can either shout it out loud or you can use your kind of thumb barometer here. How comfortable are you talking with patients and families about mental health, emotional wellness? So if you're all the way up here, you're like, I could go do it right now. Here, some stuff is okay, some stuff is more challenging for me. Here is, I want to keep learning. I don't feel confident yet. Where are we at? Okay, yeah. So I see a wide variety in the room, and that's good. If you are here, that means that hopefully a lot of this will be a review and you can sharpen some of those skills. And if not, if you're somewhere in the middle or feeling less confident, then hopefully you get to take away some strategies that you want to try today. The goal is not to be perfect at this. The goal is to try it out. Take some of the strategies that we just go through, make them your own, make it authentic to you and the language you use and the way that you're used to speaking with your patients. And if you have some questions, we're going to talk through those too. So the reason why it's so important for you all to be able to speak to physical health and mental health is because young people and families often trust you. A lot of the time you are serving as that SSNR in their lives, and you can work to support their caregiver in being an SSNR in the lives of their young person. So when we say that, it's a safe, stable, nurturing relationship. Safe, meaning free from physical and psychological harm. Stable, meaning predictable and consistent. And nurturing, meaning being responsive to the needs of each unique individual child. And we know that youth who have at least one SSNR in their life are more likely to develop that sense of resiliency. So this is really what we're going to spend the core of the rest of our time doing together. We're going to go through these circles, building blocks for resilience. These are all evidence-informed. Circles is just simply the acronym that we use to be able to remember all of these glorious evidence-informed themes. But as we go through each one of these, what I really want you to think about is which one of these do you feel confident in already? That's important to celebrate what you're doing. We don't get a ton of breaks during the day or time to reflect and think on what we're doing well. And I think that's really important. I also want you to be able to think about which one of these you want to continue to try and add more tools in your toolkit for. And I also want you to think about which one of these you want to be able to speak to families more with. So our first resilience building block is communication. So communication builds resiliency by teaching children how to effectively connect with others and share their needs. So we know that youth are not born telling us what they need, right? That would be amazing, but that is not the case at all. So we know that youth depend on their caregivers and other adults to be able to help them meet their needs. And we want to be that bridge as adults that helps listen to and observe what we see and try to help them name those needs so that as they age and grow, they're able to say, this is what I need, right? I'm feeling really tired. I need to rest, as opposed to what we might often see throwing a chair across the room, right? Or I'm just going to stop right here and throw my hands up and just cry, right? So those types of things, those behaviors, we like to say that behavior is communication. I have heard that so much in my youth work, all throughout different states and cities. Behavior is communication. So we want to take those behaviors that we're seeing and we want to help young people start to label those feelings. And we do that through a couple of strategies. Talking about our feelings daily, having open conversations, and especially being able to just use open-ended questions. So there's nothing wrong with a yes-no question. We're just always going to get a yes-no answer, right? Some of the time those are really important, especially as we're going through our checklist. But something that I want to invite everyone here to be really mindful of and intentional about is keeping track of how many times are you using a yes-no question and when are you able to open that up a little bit more. So we can go through some examples after this, but essentially just being able to say, instead of, did you have a good day? Is school going well? You're feeling okay, right? Those are all yes or no questions. We want to try and open those back up. So talk to me about how school is going, or what was the most challenging part of your day? What's something you're really proud of that's going on at school right now? Talk to me about home. What's something new that you're learning there? So we really like this kind of visual of an iceberg because I think this is really what communication is about and how powerful it can be. Some of those behaviors or some of those symptoms are what we might be seeing above the water or above that surface. And we really want to be able to take that conversation, open it up to see what might be going on underneath the surface. We want to get curious about that. And I think it's really important to really focus on that curiosity rather than that knowing or assuming, because what looks like anger or frustration or sadness for me might look totally different for someone else, right? So if I'm angry, it's usually because I'm hungry. Whereas for some young people, it might be they're feeling really frustrated. They're way beyond the level of their math and they're bored in class, so they're frustrated with it, right? So again, when we open that up with those open-ended questions, usually starting with who, what, where, when, or why, those are the kinds of conversations that can really help us to understand, oh, maybe this is related to something else. Next, we have independence, which builds resilience by developing a child's confidence to try things on their own. We want to encourage caregivers to allow their kids to try things on their own. We want to allow them to make safe mistakes, meaning where they're free from harm or where there's a really low risk for any type of physical or psychological harm. And one of the really great ways that we can go about building that independence and kind of fostering that agency is by offering choices. Our young people are told no so often. Unfortunately, that is like quintessential to being a kid, right? Don't do this, don't do that. No, we're going over here. You can't do that. So we want to be people that open that up and give some of that power back to them so that they're feeling a little more agency, especially when it comes to their own body, their own needs. So whenever we can, we want to be able to offer choices. So maybe there's a part of the well visit that I can say, hey, do you want to talk about school first, or do you want to talk about how you've been feeling physically? So we can offer that voice and choice whenever we can. For a vaccination, for example, even something as simple as, we do need to have a vaccination today. You're up for your immunization shot. You get to decide. Do you want it in your left arm or your right arm, right? So something as simple as that, we get to give them back some of that agency. So I want you all to think about some of those common examples where you can incorporate that. A really great way to do this, and what it says up here, is offering a forced choice. That is simply a this or that kind of choice. So that narrows in where for some youth, especially younger youth, or maybe our youth on the autism spectrum, where a lot of options can be super overwhelming. I know that's the case for me too. Just being able to say, do you want the sticker or do you want the mint on your way out the door? Rather than, what would you like to have? So really think about how you can continue to empower your patients and families through choices. And next we have routines. These build resiliency by creating a sense of safety and predictability. I think routines are absolutely essential to healthy youth development. I think one of the reasons COVID was so hard for all of us is because it threw us all the way off our routines, right? Or how many of us get to go on trips or vacations or staycations where you get to relax. It's amazing. You love going for a couple days, maybe a week, maybe 2 weeks. Maybe some people out there are like, nope, 2 months would be ideal. But after a while, you might start to get that feeling of like, yeah, this was a really good experience, but I'm kind of ready to get back to my routine and get in the flow, right? So we crave routines and consistency as human beings. And our youth sometimes might be showing the exact opposite of that, right? That they don't want those rigid kind of rules, but they really thrive more with routines. So we want to be able to focus on sleep and wake routines with families. We want to be able to create healthy habits around those. So for example, if we're talking about sleep routines, instead of being able to say, hey, you got to sleep more and keeping it at that, I know we don't have any more minutes than 10 to 15, depending on the number of siblings that y'all are connecting with, but if there's even a little bit of time to just be able to say, sounds like sleep has been hard lately, talk to me about what the nighttime routine is, right? And maybe that's where we talk about deep breathing or some coping skills like progressive muscle relaxation, where we're doing some tense and release, right? We're getting our body and our mind kind of ready to start to wind down for bed. And if we're teaching those skills to a caregiver and a young person, maybe that's something that they can do together before bed, right? Because whatever regulation skills that we're going through with children, it's just as beneficial to be talking about those in front of caregivers and to be modeling how important we think those are for development. We also want to create family routines around healthy communication. You all know your patients and families best, so I know that in the past this might have looked like an hour-long sit-down dinner. We're busy humans. Our patients are busy people too, so we want to be able to find different ways and partner with them and ask them questions and give them some ideas to help them figure out, if it's not that, maybe at the end of the day, we're doing what I just did before. How was your day? Give me one of these. And maybe they're telling us, oh, it's in the middle. Talk to me about what that means, right? So just having some more communication. Next, we have coping skills, which build resilience by teaching students how to manage their emotions. By students, we mean all young people. So we want to teach new skills when everyone is calm. We want to practice these regularly. We want to try lots of different skills, and we want to be able to model those healthy coping strategies ourselves. And we're going to go into why it's really important to practice those while we're feeling calm in a moment. But just some more things to keep in mind when we're bringing those coping skills into our provider space. We want to suggest these without forcing them, because we want this to be a pleasant introduction. We want them to be able to see, is this something that I like? I want to be able to try it and see what feels good, what doesn't. So we do not want to force anyone to do a coping skill unless it's something that they're open to trying. I know for me, I love deep breathing. I love going for walks. If someone asks me to journal to try and get calm and balanced, I may smile and nod, but I will know that does not work for me. Journaling is a great coping skill, right? Simply not for me. Tried it multiple times. Not for me, and that's okay. So you all know what things work for you, and you can continue to find that out. And those are the things we really want to build for our patients and young people. So that doesn't mean saying, okay, pick this, you don't need to do that. It just means, have you tried this before? What was that like? What didn't you enjoy about it? We also want to follow the child's lead based on their comfort level and recognize that the office might not be the most comfortable space. So maybe we say, I want you to pick one of these and I'll show you how to do it. And then if you want, you can try it tonight. Maybe you two can actually try it together. Or maybe you and your sibling can try this. And remember, what works for one child doesn't always work for another. Just like I said, for us as adults too, coping skills are not a one-size-fits-all solution. So we have to try a variety, and we have to try them at different times in different scenarios to really be able to figure out what we need. So this is the hand model of the brain. Has anyone heard of Dan Siegel before? Maybe. He does some great work with trauma and how that can live in your body. But he started to do a lot more than just talking about what we can do when challenging or adverse experiences happen, but really just how can we help ourselves to regulate and get back to that sense of balance and calm. So this is something that I actually like to do with young people. So you can do it along if you'd like. No worries if you're not feeling it today. But essentially what I do is I just put up my palm, I take my thumb and cross it across my palm, and then I take my other fingers and I wrap them right around that thumb. So this is our hand model of the brain. We have our brain stem here. So when our system is like this, it's online. So this is our calm brain. I'm guessing most of us in the room have this kind of online system going on right now, right? We're taking deep, slow breaths. We're engaged. We're listening. We're able to learn and process new information. We're thinking rationally, we're reasoning, right? So what happens when our lid is flipped? We are stressed, we're overwhelmed. Maybe we are running from our car to this presentation up the stairs. Not naming names, it's me. When our lid is flipped, essentially what that means is that we automatically are going into fight, flight, freeze, or fawn mode, right? So it's really important, I think, to be able to help young people and their caregivers understand that that's not a choice, that it's happening automatically. And the reason that we're practicing these coping skills when our system is online is because that's when we can take new information in, right? That's when we can learn new things. And that's really going to help us when we get to this place where our lid is flipped, whether it's for kids or adults. We're going to be able to get back to this calm. The more that we have practiced those coping skills when we're calm, the more that we've tried different ones, then our body remembers, and it's going to help us get back to that state of balance. I also think this can be really helpful when talking with caregivers about how when our lid is flipped, we can't think our way out of that, right? So if I'm super upset and if someone says to me, okay, just calm down, right? Right. Yes. Thank you. That is exactly right. So we can't just calm down when we're really stressed or really overwhelmed, right? That would be super convenient if we could. But usually it does the exact opposite because it's frustrating. We can't just think our way out of it. We would if we could. So we got to be able to partner with our body, slow things down, and get back to that balanced state. So I think that can be really empowering once families start to know my child is screaming and going wild all over the place. I don't know what to do. I keep telling them to calm down, right? So being able to say, actually, I just learned something. In those moments, it's really not a choice. So we got to work with our bodies to be able to bring it back down. And then when you start to see slower breaths, and when you start to see those fists start to get unclenched, that's when you can start to have those conversations about, talk to me about what's going on. What was the thing that upset you? Let's figure out what happened. So we have some coping skills practice. These are 5 different categories. I'm going to call on some help and support from all of you. This is a handout that we have. It's in handout form, and we have it in poster form as well. It's available to print on our website, but we'll also go through at the end. If 50% of your clinic is taking these trainings, then you get an awesome toolkit, and then you just get to order these kinds of handouts and keep ordering them, as many as you need for your patients. When they run out, you order them again, and it's all free just because you have taken our training. The only reason that we want that to happen is because we want everybody to feel really comfortable using these and incorporating them into their well visits. So more on that after this. But for our coping skills practice, I'm going to go through each category at the top. And I want you all to think about, what is your go-to coping skill? Maybe it's something that you do when you're feeling calm because it feels good. Maybe it's something that when you're really stressed, this is something that helps you return to that state of balance. And if that category applies to you, if it's be active, I'm going to say it out loud, and I want you to make some noise like, woo, woo, that's me, so we can hear one another and know that there's a variety of coping skills in the room. So if you are someone when you're stressed and overwhelmed, you like to be active. Where are you at? Oh, okay. Yeah, okay. I saw a casual hand raise. We do have some. Yeah, okay. Thank you. Walking counts. Anyone enjoy walking? That's me. Only running I do is I already told you about it today. So, finding your calm. Who likes to find their calm? Maybe you're having a drink of water. You're doing some deep breathing. Yeah, awesome. Okay. What about getting creative? Maybe you are painting. You're writing things down. You are playing a song. You know your music that you like that helps get you to a calm space. That one I am jealous of. I'm going to keep practicing my creative coping skills because those do not come naturally to me, but I really like that. Connecting with others. You hop on a phone call. You got to talk it out with your person, right? Maybe you just need to ask someone for help. You can write a letter and tell someone, this is what was going on. And shifting your mindset. Maybe you're focusing on what you can control instead of all of the things that feel out of control. Anyone? I forgot to do the woo-woo thing, so some of you got off the hook. But one of the great ways to be able to use this, especially with teens and older adolescents who might not be the most forthcoming with sharing out all of their favorite coping skills, you can use this just as a handout and say, hey, I want you to take a moment and look at these. Can you circle 3 things that you're already doing to stay healthy? And then maybe we talk about those, and then I'm going to say, all right, I'm going to have you look at this list again, and then can you star something that you would be willing to try at least once, maybe a couple times between now and the next time you see me. And then if you need to, you can kind of add a little bit more to that. The reason that I'm talking about this, it might seem kind of awkward that I'm talking about this with you. Maybe it doesn't, but it's because it's just as important to take care of your mental health as it is your physical health, right? So practice incorporating that into your language. Again, you know how to make it authentic. You know how to relate to your patients best. But try practicing, because I know for me, it's been incredibly awkward the first couple times, but once I've found my groove, it's felt a lot more comfortable. Next, we have limits, which build resilience by teaching children to understand boundaries and expectations. So we want to encourage caregivers to use limits to teach rather than to punish or control. We want to offer simple choices, and we want to set reasonable and relevant consequences. I think limits can be really helpful when we're talking about communication, relating those back together. So when we're setting limits, we want to encourage caregivers to do that with the behavior as opposed to the feeling. So I used that example before of, I'm so upset, I'm so angry, I might be throwing a chair across the room, right? Or I might be shouting. Those things are the behaviors that we can set the limit on, but we want to be able to validate the feeling that's underneath it. So, hey, it is not safe to throw chairs. It's okay to be angry. Let's talk about what's making you angry, right? So we want to encourage caregivers to be doing that. Next, we have emotional expression, which builds resilience by allowing children to express, process, and manage their feelings. So we want to help caregivers and children label those feelings. The reason that we do that, there's a phrase that Dan Siegel, the same person that does the hand brain, says, name it to tame it. So I like that. It sticks in my head really well. And what it's really essentially saying is that the more that we know about our feelings, what it looks like in our body, what happens when I'm angry, right? My shoulders might go up here, my hands get balled up into fists if I'm angry. When I know what's happening in my body, when I can name what that feeling is, often I know what to do with it. It doesn't mean I need to push that anger away. It's okay to feel that feeling, but what's something productive I can do when I'm angry rather than throwing the chair? We want to allow all feelings. One thing we like to say is feelings are not good or bad. They just are. And if you grew up how I did, there were absolutely bad feelings, right? When I say bad feelings, what are some feelings that come to mind? Anger, yeah, right? It's not one that is super socially accepted still, right? What else? Frustrated, sadness, right? Being incredibly sad, it's a feeling. Jealousy too, those are bad feelings. We want to be able to help ourselves and help our youth understand that feelings just simply are. And when we put them on that equal playing field, we can really normalize those feelings and we can open up conversations about them. And the more we're doing that, the more that we can help to destigmatize mental illness and support mental health more. We also want to offer different options for safe expression. We just talked about this. What works for one person might not work for another. What works for me today might not work for me tomorrow because maybe I'm in a different mood. Maybe I'm in a different situation. So again, keep helping patients to build those toolkits. All right, we made our way all the way around solving problems. This builds resilience by increasing confidence to navigate future challenges. Between this and independence, I think we're really focusing on some things that can help to raise some young people who are ready to be able to take on challenges, right? We don't want a ton of youth growing up to think that they need to be perfect and need that direct support all the time. We want to foster that independence, and we want to help them understand how to solve problems. We want them to know that it's okay to make mistakes. And we might not want to share our largest mistakes as adults, and especially as providers. We might not want to just share our biggest mistake. We want to be able to instill trust, but a low stakes mistake is okay to share. It's actually super helpful for young people to know that we as adults make mistakes too. So failure is an option, and that's often when we learn the most. Another really great way to be able to have conversation about solving problems is a really slight shift in our language, but just using how instead of why questions. So this might be similar to the calm, flipping our lid kind of feeling, but when someone asks a why question, when there is a problem that's going on, how might I feel if I say, why did you do that? How are you likely going to feel? Exactly, yeah. Feel attacked, feel like someone's accusing you. That can really get our defenses up and have us on guard. Maybe a young person is starting to think about, okay, I got to come up with an excuse. That's good enough. Why did I do that? So it's a super slight shift in language, but one that we want to be mindful of is trying out how and framing it around that. Talk to me about how we got here. Let's have a conversation about how we handle this when it happens again, right? Young people are going to fight with their siblings, right? That is inevitable. They spend a whole lot of time together, and usually they're not the same exact person. They have differences, and that's where they navigate things through play and through arguing with one another. So we know that's inevitable. So how can we talk about what's going to happen next time? And we want to allow for natural consequences, again, as long as our patients are in safe situations. So these are our resilience sheets. Again, these are on our website, and you can print these out for free. And they include all of these strategies that we were just talking about with our resilience building blocks. These large circle letters are not actually on the page. That's just more to give you a sense of how you can incorporate all of those throughout your talking points. And these are all kind of grouped by age and developmental level. So I think that can be super helpful too. I've known providers that have used this as talking points throughout their well visit. And I know others who have really effectively just been able to mention it, staple it to the forms as the family's heading out the door. And that's something that they can explore on their own time. These are our resilience toolkit materials, and this is hopefully the only time I sound sales pitchy, so I apologize, but these are the items that you can order endlessly if you're clinic is able to take the training. It just needs to be 50% or more of the people at your clinic to take the training. We offer it virtually and in person. I will drive out to you. I really appreciate being able to spend time with all of you. So if you found this valuable, feel free to just find our information on our website at strongforlife.com. You can register people for another training. We also offer them monthly. So some of the things that we talked about are our coping handouts. We have one-pagers for all different coping strategies: deep breathing, journaling, progressive muscle relaxation, grounding, all of those good things to be able to support patients. And then we'll go through a couple of other things that we have. These ones, again, are all free on our website to just be able to print out if you would like to. These two handouts really focus on communication and emotional expression. So some communication strategies that we didn't get a chance to go into as deeply are active listening, right? So that nonverbal and those verbals, nodding, showing that I care about what you're saying. And I know that sometimes we're actively taking notes, we're typing notes on the computer while we're getting told a lot of different updates. Sometimes listening actively is just as simple as saying, I'm going to write this down. I care and I want to remember for next time. So I'm listening to what you're saying. I may just be typing too. So just giving some transparency to that. Reflecting is a great strategy for being able to share back and reflect what you're hearing. So you can do that directly by just saying what you heard someone say, and then asking, does that sound right? Otherwise, you can give kind of a summary. So what I'm hearing from you is that social studies has been really challenging this year, and that your teacher doesn't call on you, and that's making you feel disappointed. Does that sound right? Or I'm hearing that your head's been really hurting. You've been getting more and more headaches. Does that sound right? Does that sound like what you just shared? So then it gives patients a chance to tell us, yes, that is what's going on. You're on it, you're tracking, or no, that's not what I said, right? I'm actually feeling this way. We also want to be able to incorporate different emotional expression strategies, like normalizing feelings and naming feelings. And again, we talked about this, but if there's anything that you take away from today, I would hope that it would be that feelings aren't good or bad. They just are. So we want to be able to normalize those feelings. Again, even if we're seeing some unique behaviors, we want to be able to set limits on that behavior, but validate that feeling. It's okay to be sad. It's actually totally normal. I get sad sometimes too. Here's some things I do when I get sad. What do you do? And we want to help name those feelings too. So these are our feelings wheel and emoji feelings. Here's some more coping skills sheets. The one on the left comes in poster form. So I love visuals. It can be a really great way to just add them into your conversations. So tell me about which one of these you've used this week. Which one of these have you tried so far? Which one have you tried that you don't like and you don't want to do again? Because that's okay too. And then just to review, talking about those healthy habits, all of these things I'm sure you're used to doing, and I'm sure a lot of you are doing an incredible job of incorporating mental health and emotional health strategies in the work that you're doing. Our goal is really to just be able to be more intentional about it and put a name to it and help with those things like labeling and expression of emotions. So we know that all of the strategies that we named from a prevention lens, our goal is to be able to use all of those, but we know that there will still be some young people who will benefit from some additional supports. So we want to be mindful of that too. So we've created a behavioral and mental health referral sheet that's also on our site. This can be super helpful for caregivers because we know that the mental health system can be super complex and hard to understand. I've been working in the system for over a decade, and it's still complicated to me to be able to navigate things like insurance policies changing and what's covered and where families can get access. So we want to be able to make this just a little simpler for families. So this kind of tip sheet breaks down different types of clinicians. So if they're seeing letters behind someone's name, they can kind of get a sense for what does this person actually do? What service are they providing? What's the difference between a therapist and a psychologist, and those kinds of things. So just some really general information on types of therapy, questions to ask when families are searching for a mental health care provider, and some things to know about therapy that can be helpful. And on this sheet on the back, it has a QR code that links to helping families find a clinician here in Georgia, and it is categorized by county too. So lastly, this is just a little bit of information on types of care. Again, something that you may be super familiar with, but it can be really helpful in conversations with families when we're talking about mental health, to be able to help them understand kind of how this system of intervention goes. So we talked about prevention strategies all day long. They're great. We can do them with all youth. Youth that might need a little bit of additional support when it comes to mental health are most likely always going to start in this blue area over here. So outpatient counseling services, which is just a fancy way of saying therapy, or medication management services. And not all families want to do that, and that is absolutely okay. But if they are seeking out support, that's likely going to be a really great place to start. Over here in green, that's where we start to get to even more intensive services. And these start to be more on a referral basis, and ending over here in inpatient programs or residential programs that are the more intensive forms of support. And then these are some great referral options and just numbers to have handy when we are talking about mental health and different ways to continue supporting our patients and families. GCAL is on there, the National Suicide Prevention Lifeline, 988. I love sharing that with patients because you can call or you can text. So a lot of young people really appreciate being able to just text. I don't know many youth that actually make calls these days, so truly I think that's a great option to be able to text for some additional support. And then we also have our Children's Behavioral Health Advice Line. Again, behavioral health can be incredibly complex, so if there's a situation that you are experiencing with a patient that you are unsure of what to do next, feel free to call, and somebody will be there to help support you and kind of talk you through what next steps could look like. So some key takeaways, wanting to incorporate mental health and emotional wellness into your well visits and in your patient-facing interactions, being able to incorporate things like resilience sheets or even just those resilience talking points, being able to offer some coping strategies to your families and patients, and then being able to utilize any resources and next steps that you heard from today or that you saw that stood out to you that you want to be able to utilize. We also have a ton of resources on our page. I'm from our behavioral mental health pillar. We also have a nutrition pillar. We have a injury and illness pillar, and we have a child safety and protection pillar. So all of those articles and resources and handouts are all housed in the same place, all from a prevention lens on strongforlife.com. We have some great handouts, articles for caregivers if they're unsure about how to talk about certain things. And then we also have some great links to videos. I love being able to shout those out to caregivers because at the end of a long day, I feel like the last thing a caregiver might want to do is be able to talk through a guided meditation or some deep breathing, but they can just hit play and there's this incredibly soothing voice that just talks people through a coping strategy like deep breathing, again, to prepare our minds and bodies for resting, I use this all the time as an adult, and I really enjoy it. So I encourage you to try it if that sounds nice. And we are in our 3rd year of our Raising Resilience campaign. So feel free if you'd like to. This is on our website as well. Otherwise, you can join the Raising Resilience mailing list. That just gives you kind of bite-sized nuggets of information about some of the things that we talked about today. And it's delivered monthly, only once a month, truly. And then if you enjoyed this training, we have other trainings in different areas. Some of you might be familiar with these already or may have taken some of them, but we have motivational interviewing, which can be really helpful when it comes to change talk. So our primary focus for that is raising healthy eaters and obesity prevention. So that's kind of the lens that we use for that, but it can be really helpful for any type of change talk motivation that you want to use with families. And then another training, Raising Healthy Eaters, just talking about strategies for supporting family with healthy eating habits. This is my information. Erin, my colleague, was the one that talked to you earlier about suicide prevention, and this is both of our contact information. Please feel free to email me at any time if you have questions that we don't get to today. If you tried strategies out and you want to share how it went, whether it's a success, I love hearing about those, or whether you say, I tried it, it didn't go well, what are you doing? That's okay too, because it's good to try things out and we can always collaborate. I'd love to be a thought partner. If you try something and it didn't go as well as you wanted, we can kind of try and formulate a different response because I want to be able to support all the work that you all are doing. So thank you so much for your time. I really appreciate it. And I don't know if we have a moment for questions. We have time for questions. All right. Post lunchtime, no questions. Cool. Well, you will hopefully have my contact information if any questions do arise. Otherwise, thank you again.
Thank you.